I'm just going online. Uh, as we have already told, the first team makes a presentation for 10 minutes. The second team gets 20 minutes to ask questions, and their role reverses subsequent to that. And that's how we are going to proceed with the meeting. So let's start the program with Government Medical College Calicut making the first presentation. You share your slides, please. You're muted. It's visible. You're muted though. Yeah, go ahead. Your time starts now.
Respected faculties and my dear colleagues, a very good evening to all. We, representing Government Medical College Kozhikode, present the case of Mr. X, 44-year-old male, who is a tailor by profession, hailing from Arakunar, Kozhikode, Kerala. Presented with complaints of swelling in front of neck for past 1 year, history of present illness. The patient was apparently normal 1 year back when he noticed a swelling in front of his neck, which was initially 2 into 2 centimeter according to patient, insidious in onset and gradually progressive to present size. No history of associated pain or fever. Apart from the swelling, he was asymptomatic and there was no history of change in voice or difficulty in swallowing, no history of heat or cold intolerance, no history of loss of weight in spite of good appetite, no history of weight gain in spite of loss of weight, no history of irritability or insomnia or tremor, no history of palpitation or chest pain, no history of double vision or bulging of eyes, no history of recurrent episodes of syncopial attacks, no history of altered bowel habits, no history of any other swelling in neck or other areas of body, no history of breathlessness, hemoptysis, abdominal pain, jaundice, abdominal distension, bond pain, back pain, recent onset headache or seizures which is suggestive of any metastatic disease. Past history. Patient has no history of irradiation in childhood to head, neck, or chest. No history of any chronic illness in the past. No history of previous surgeries. Personal history. He follows a non-vegetarian diet, regular bowel and bladder habits, normal sleep and appetite, no addictions, and there was no history of any chronic drug intake or drug allergies. Family history. No history of thyroid disorders in family. No history suggestive of any malignancies related to thyroid, breast, endometrium, or pancreas. Socioeconomic status. He belongs to a lower middle class family according to modified Kuppuswamy scale.
So on general examination, the patient is conscious, cooperative and oriented to time, place and person, moderately built and nourished. Karnofsky performance score is 100, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. The height is 170 centimeter, weight is 72 kgs, BMI is 24.9. So pulse rate is 82 per minute, regular in rhythm, normal character and volume, no radial or radiofemoral delay. Blood pressure is 130 by 80 millimeters of mercury measured in right upper arm in sitting position. Respiratory rate is 14 per minute. Patient is afebrile to touch. No features of marfanoid habitus, no exophthalmos or eye signs, no pigmentations or oral mucosal lesions. Palms on examination not moist or no fine tremors. So on inspection, a smooth ovoid swelling with well-defined borders present over the anterior aspect of neck towards the right side of midline, approximately of size 5 cross 3 centimeter. Superiorly, the swelling extends approximately 2 centimeters below the thyroid notch, inferiorly up to suprasternal notch, laterally till the medial border of sternocleidomastoid, and medially 1 centimeter lateral to the midline. The swelling moves up with deglutition. Trachea seems slightly deviated to the left. Lower border of swelling clearly visible on deglutition. No dilated veins, sinus, scar, visible pulsations. No other swelling visible on the neck. Pemberton sign is negative.
So now coming to palpation, there was no local rise of temperature or tenderness. Trachea is deviated to the left. A solitary firm ovoid swelling of size 5 cross 3 centimeters with well-defined borders and regular margin, smooth surface noted. Superiorly, the swelling extends 2 centimeters below the thyroid notch, inferiorly up to the suprasternal notch, laterally till the medial border of sternocleidomastoid muscle, and medially 1 centimeter lateral to midline. The lower border was palpable. Carotid artery pulsation felt bilaterally equal. Left lobe of the thyroid on palpation appeared normal. There was no thrill. Examination of the cervical lymph node. A mobile right level 3 cervical lymph node measuring 2 cross 2 centimeters present on the right side, which is firm in consistency with regular margins noted. No left cervical lymphadenopathy noted. On percussion, there is a resonant note heard on percussion over the manubrium sterni. On auscultation, there is no bruit heard over the swelling.
Coming to the systemic examination, on respiratory system examination, there is normal vesicular breath sounds, bilateral and equal, and there is no added sounds. On abdomen examination, it is soft, non-tender, there is no organomegaly and no evidence of any free fluid in the abdomen. The skull and spine appears to be normal, and nervous system examination, there is no focal neurological deficits. Coming to the summary, it is a 44-year-old male with no non-comorbidities and no previous history of surgeries, presented with complaints of swelling in front of neck for the past 1 year associated with gradual increase in size, and the patient is asymptomatic otherwise. On examination, there is a solitary nodule of right side of thyroid of size 5 into 3 centimeter without any signs of retrosternal extension. There is also significant right level 3 cervical lymphadenopathy. The patient is euthyroid clinically with no features of local infiltration or distant metastasis.
Thank you,
So our
team.
clinical diagnosis is solitary nodule of thyroid with right level 3 cervical lymphadenopathy, probably papillary carcinoma of thyroid with cervical lymph nodal metastasis, clinically euthyroid.
Thank you, team Calicut. Team Trivandrum has got 20 minutes for question. Your time starts now.
Very well presented, guys.
Thank you.
Firstly, since your diagnosis is a papillary carcinoma of thyroid, what is the incidence of malignancy in thyroid swelling?
In the case of a solid lesion, there is 24% chance of malignancy in a male patient.
Okay. It can also, there is also evidence that statistics say that 10 to 15% of thyroid swellings present with malignancy can have malignancy. So apart from that, what are the positive points in history that contributed to your diagnosis? Just in history.
So this is a male patient presenting with the swelling in the anterior aspect of the neck. And so it is a thyroid swelling by our clinical history and examination. And the patient has also got a significant level 3 lymph node over the right side.
Sure. Also, also the gradual progression of size and but is it common more in males or females?
Of course,
Thyroid
Of course, in
malignancy.
females.
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 But,
All right.
but a male patient presenting with a thyroid,
Sure.
solitary node
Sure.
thyroid, there is more chance of development of
Okay.
malignancy.
What is the importance of age in your setting in this condition?
Age is very important, and age at diagnosis is an important prognostic factor in case of thyroid carcinoma. So
Yes.
now we consider age as 55, and this patient is a 44-year-old male. So he is whether if there is no metastasis, he will be in stage 1 itself and has a very good prognosis.
So, see, the prognostic score assessment is from ages, ACEs and MACEs. But in that, is it age 55? What is the cutoff?
According to recent 88 2025 guidelines, it's 55, but it's in literature
It's
it says
actually
50.
common age. I think common age cutoff is 40, and
40.
55 is in staging. AGCC staging is. Thyroid malignancy is the only cancer where age is included in staging of this. Okay. So in history, you asked for cough and history of metastasis and all. So how do you rule out retrosternal extension in history itself?
History of breathlessness.
While lying down.
Dyspnea on lying down can be a symptom in patients with retrosternal extension, but this could be a symptom in cardiac failure also. Patient can have orthopnea if the patient is toxic features is there. But in this patient,
sorry. To be precise, it is postural cough actually. That is the characteristic thing in history that you asked for retrosternal extension. So you said that there is no voice change and no history of any tracheal compression and all. So what could be the reason behind voice change if the patient presented with that symptom?
It can be because of the infiltration of a recurrent laryngeal nerve, or maybe because if the patient is hypothyroid, the patient can have laryngeal edema. That may be the reason of voice change also.
Correct. So you said recurrent laryngeal infiltration. What are the boundaries of Riedel's triangle?
Riedel's triangle is bounded laterally by the recurrent laryngeal nerve, superiorly by the inferior thyroid artery, and medially by the
it's laterally by the common carotid artery, and the apex
artery
will be towards the lower,
lower,
and the base will be inferior thyroid artery, and medially it will be the recurrent laryngeal nerve in Riedel's.
No, that is actually recurrent laryngeal nerve is a content in Riedel's triangle. The medial border is formed by the trachea actually.
Yeah.
Okay. So you asked for features of hyperthyroidism and hypothyroidism in this patient. What is the relevance of asking such things in a malignancy? Is there any relevance?
Usually in malignancy, they won't get hyperthyroid because in malignancy, the trapping thyroxine synthesis followed by at last even the thyroglobulin synthesis will be also lost. So this will be lost in a step-by-step manner in malignancy. So usually patient will be, if at all, patient can be a hypothyroid but never a hyperthyroid. It is very rare.
There is a statistics that there is less than 1% chance of
1%
follicular
chance
carcinoma presence with hyperthyroidism. And also, there is some evidence that 8 to 15% of hyperfunctioning nodules can harbor malignancy. So, yeah, that is what I was looking for. So, you said there is no history of radiation exposure in this patient. What are we looking for actually? Anything specific in radiation? Is it dose dependent?
It's a low dose radiation. It is given for a long time, can actually cause. A high dose is mostly an ablative one.
Low dose radiation is what is significant. And see, is there any relevance and significance in asking history of environmental radiation in our setting in Kerala? As you know, Chernobyl is an international incident, but in Kerala, is it really relevant?
In Kerala, actually, we have Kollam and that area with some thorium effect. But as per literatures and as per till now the meta-analysis, there is no evidence of causing any malignancies.
Correct. Yeah, in Kollam, Chavara, Karunagapalli, along the seashore, yeah, there is increased thorium content. You're absolutely right. So, in dietary history, what are we looking for actually? What are the goitrogens in the diet?
Brassica family, cabbage.
And what is the relevance in malignancy actually? See, in an iodine deficient state, what is the most common malignancy that you get?
Follicular.
Correct. Yeah. And what about in iodine sufficient state?
Papillary carcinoma.
Correct. Absolutely right. In personal history, you mentioned about bowel habits. Here, the patient had no alternating bowel habits. Is there any condition where you get diarrhea in malignancy?
Medullary
carcinoma thyroid.
And what would be the reason behind it?
It's because of the secretion of serotonin and others which can cause.
So in 30% of medullary carcinoma, you get diarrhea. That is serotonin induced. There is also studies that say that calcitonin can also induce diarrhea. You're right. So apart from this clinical scenario, I would just like to ask that, can a thyroid malignancy patient present with bleeding PR? Actually, yes, there can be because familial adenomatous polyposis, FAP. FAP, yeah. So there is a syndromic association. It is associated with cribriform variant of papillary carcinoma of thyroid. And lastly, can you name a few genetic syndromes that are associated with thyroid malignancy?
So there is Cowden syndrome, which can thyroid carcinoma can be part of it, and then there is a Wermer syndrome, which is a progeroid syndrome. Then there is FAP, as you have already mentioned, familial adenomatous polyposis. Then there is McCune-Albright syndrome, MEN syndrome, as already said, and Carney complex as well.
Correct. Yeah.
Okay. Now coming to our clinical examination, what are the clinical features which are suggestive of a thyroid swelling in this case?
Swelling is present in its anatomical position of the thyroid. Yes. That is the first thing. Then it moves up with deglutition. And in swelling in the midline anterior aspect of the neck, unless and otherwise proved, which is moves with the deglutition, is suggestive of a thyroid swelling.
Okay. Do all the thyroid swellings move with deglutition?
If there is any severe infiltration to the strap muscles, there can be very large swelling.
Or prevertebral fascia.
Prevertebral fascia, there can be restriction in mobility.
Very large thyroid swelling.
Very large thyroid swellings and also in very huge retrosternal extension also. So you were mentioning in our case, the lower border is reaching up to suprasternal notch, right? What's its relevance?
There can be, the one thing is there can be retrosternal extension, but on deglutition, we can actually visibly see the lower border. So there may not be a retrosternal extension until there can be some small twig that is arising through which another intrathoracic retrosternal goiter can coexist.
Okay. How will you then clinically, how will you find out the retrosternal extension?
We can palpate for the lower border, that is the one thing. Then next we can go for the Pemberton sign. We'll ask the patient to raise both hands and we look for the congestion of the face. And the next one is we'll palpate we'll percuss over the manubrance journey to see whether it is dull or resonant.
What if it is dark individuals? What will you look for?
Conjunctival
What are we
congestion.
looking? Yes.
Conjunctival
Conjunctival
congestion.
Correct. So do all the goiters with retrosternal extension having positive Pemberton sign? Do they have any exceptions?
Plunging type of
Also in
Plunging type.
primary.
Primary.
Primary. Yes, correct. So what was the consistency of our swelling?
In this case, it was a firm swelling.
Firm in consistency. What are the, do you know some conditions which are getting hard in consistency in swelling?
Anaplastic carcinoma, thyroid can cause
Yes,
hard.
correct.
And even
any other swelling like in
long-standing MNC, if there is calcification, you can cause
correct. Yes, also in
Reduced
thyroiditis.
reduced thyroiditis also.
So yeah, okay, correct. What's thyroid? You know what's thyroid paradox?
Sometimes sometimes malignancy might be a soft swelling, and also sometimes thyroid cystic swelling, a benign one will be palpated as a very hard swelling.
Especially the tense swelling, tense cystic swelling, benign cystic swelling. That's correct. What was the consistency of a lymph node in our case?
In this case, it was firm. It was
firm. Yes, correct. You know some conditions which we are getting soft in malignant condition, which we are getting
carcinoma. You can have soft cystic consistency for this.
And also in some other condition general, other than thyroid swelling. Sometimes in case of bronchogenic carcinoma, in some conditions of squamous cell carcinoma, we'll get it. Okay. So you examined for carotid pulsations, right?
Yes.
Where is the anatomical location of the carotid pulsation?
The normal location would be against the tip of C6 cervical vertebrae, which is known as the carotid tubercle or Chassain's tubercle. But in this case, since because of the large swelling on the right side, we actually got it some above.
Okay. What is relevant?
If it is not palpated at the normal position, it may be deviated to some side. And if there is absence of the carotid pulsation, it's known as Berry's sign.
Yes. Then what will be our staging if it's absent?
It will be T4B if there is carotid sheath infiltration.
Correct.
We have halfway through, Mark. You're halfway
Very well
through.
presented, guys. Very good answering as well. So I'd like to go into the investigation. So what is the quadruple assessment? What is meant by quadruple assessment?
It's the clinical examination followed by thyroid function test, which include the TSH, free T3, free T4, and the ultrasound of the neck. That is a radiological imaging and a histopathological investigation, which include the fine needle aspiration cytology.
Okay, very good. So in your thyroid function test, if you what will be the first lab value that you look for if you do a thyroid function?
TSH.
So what is the normal value of TSH? What is the normal range?
It's
0.5 to 5 international units per liter.
Yeah, it's milli international. It's MIU. It's not just it's MIU. Yeah. Good. So if you've tested your patient, you find out that TSH is on the higher side, slightly high. What will you do? What will be the next thing that you look for?
You have to look for the free T4.
We have to look for the free T3, free T4, and also we have to look for the thyroid antibodies. That is also something that you have to look for. Yeah, you have done that. You found it out. The next investigation. What is the next investigation that you'll go for after your lab test?
Radiological imaging have to be done, which is ultrasound of the neck.
It is a high resolution ultrasound of the neck. Ideally, 7 to 14 megahertz is what is mentioned in all the textbooks. You go for a high resolution ultrasound. Okay, you do an ultrasound. What is the advantage of doing an ultrasound in this case?
We could identify the features suggestive of malignancy, and also we can pick up the nodes. Clinically, there was only palpable one level 3 lymph node, but there can be also other lymph nodes that is palpable. Then features of malignancy, we can assess the left lobe of thyroid, where actually on clinical examination was normal. We can assess for the nodules in that. And also an ultrasound guided FNAC can be taken.
Sure. Yes, very good. So you said regarding the features of malignancy. So what are the features of malignancy on an ultrasound?
So it can be.
It will be taller than wider cells will be there. Infiltrative margins will be there. It will be usually hypoechoic, and microcalcification will be present, and lymph nodes will be able to significant lymph nodes will be
obliteration of the
peripheral.
Also, there will also be signs of extrathyroidal extension. Very good. So you've done your ultrasound, and you arrived at a score that is known as TIRADS. So what are the components of TIRADS? This is what the ultrasound gives you.
So what are the components? We have to look for the composition. We have to look for the margin. We have to look for if there is echogenic foci and also echogenicity and also the shape.
Oh, very good. So you have done your TIRADS, you've got your scoring. So what is the next thing that you will do? What is the next investigation?
Next, we'll proceed with the ultrasound guided FNAC based on the TIRAD scoring.
So what is the gauge of the needle that is commonly used for an ultrasound guided FNAC, or what in general for an FNAC in a thyroid?
23 gauge.
23 gauge.
It's ideally 23 to 27. We have a range of 23 to 27. So you've done your FNAC, it comes out as bloody smear only. So is there any modification that you'll attempt in the patient to get better result?
A guided FNAC will usually get.
Yeah, even if you miss on that, there is a technique that where you flex the neck, and also you can use a gauge, you can use a different gauge needle. That is, you can upgrade it to 30 gauge or 25 to 30, maybe 27 to 30 gauge. Use a better needle. That is all. So you've done your FNAC. So what is an adequate FNAC?
6 plus.
There are six passes with minimum cells of 10.
Yeah, 6 clusters with each containing at least 10 cells. Very good, very good. Yeah. So you've done your FNAC. So what is this TBSRTC? Can you just elaborate the full form of TBSRTC? It is the Bethesda system of reporting thyroid cytopathology. That is TBSRTC. So you've got your TBSRTC score. So in which score of TBSRTC or in which grade will you consider doing a molecular testing?
In Bethesda 3. Category 3, if it was in ATP of undetermined significance.
Basically, you have to go for molecular testing in Bethesda 3 as well as 4. It is also recommended in 4. So can you name just a few molecules that you're being tested? Which are the genes that you test for?
We can test for BRAF, RAS, RET PTC, TERT, TP53, NTRK,
Very good.
and
So
PPAR1.
is there any role for testing of tumor markers in your case? If so, will you which is the tumor marker that you'll do? Which are the tumor markers that you may do?
The case
In this particular case of papillary carcinoma thyroid, a pre-op evaluation of thyroglobulin is not required.
Very good.
In the case of
So if it
medullary
was
carcinoma,
we can go for a serum CA and serum calcitonin can be assured.
Okay. So what is considered, you decided to keep the patient on follow-up. So what is considered as a significant growth in a nodule? What do you mean by significant growth in a nodule? So it means that if there is you keep the patient on follow-up, if there is a 20% increase in at least 2 diameters or a 50% increase in the volume of the nodule, it is considered significant. Again, you have to go for further evaluations. Okay, thank you guys. Very good.
All right. So you have wonderfully diagnosed as a papillary CA with a lateral neck wound. Say the patient is having metastatic symptoms. So will you still go for what is your primary modality in that case? In a differentiated thyroid carcinoma?
In a differentiated thyroid carcinoma, anyway, we have to go for an upfront surgery of total thyroidectomy.
Yes. So total thyroidectomy. So in your case, what is the complete surgery you will be doing?
In this case, we'll be doing a total thyroidectomy with a central neck node dissection and a right lateral neck node dissection.
All right. In the lateral neck node dissection, what are the levels that you will be taking now?
For this particular case, after evaluation with CT, we have to evaluate with CT thorax neck, and then we have to take 2A, 3, 4, and 5B have to be taken in lateral.
All right. So why not level 1 lymph nodes?
Usually, it is not involved much in case of thyroid, and if at all there is suspicious lymph nodes that is present, we have to take for 5A as well as.
All right. Okay. And like even if it's involved, it will be micrometastasis that are not very clinically significant. We can always ablate it later. Say if this patient doesn't have lateral nodes. So in that case, will you still go for a central neck node dissection?
For this case, since it is a high-risk feature of more than 4 centimeter, a prophylactic central neck node dissection will have to be done. If it was not a high-risk feature or less than 4 centimeter or T1, T2 disease, we could have omitted a central neck node dissection according to ATA 2025 guidelines.
So why do we not routinely recommend in low-risk disease central neck node dissection?
Usually the survival rate with or without the central neck node dissection in case of a low-risk tumors, survival benefit is same.
Simple. There is actually an increased risk of hypoparathyroidism. That is what is going to add to the morbidity of the patient. Isn't that the most common complication of thyroidectomy? Doing this will only going to exaggerate that. So very good. So you performed the surgery. Now, when are you going to, post-op is uneventful, when are you going to ask the patient to come back and with what?
So we have to follow up in such a way that we have to ask the patient after 2 weeks. Anyway, we'll have follow up to receive the HPR. So histopathological evaluation of this specimen that we have sent.
An HPR. What are the prognostic factors that your HPR is going to give?
For the focality of the disease, whether it is unifocal or multifocal disease, size of the lesion, and whether it's what is the subtype of the papillary carcinoma that is present, whether it is a bad histology or good histology.
And what are the bad histologies?
diffuse
sclerosing variant, tall cell, hope nail, as well as columnar variant.
What are the things will you
You
look
have
for
2
in the
minutes
HbA?
more. You have 2 minutes more. 2 minutes
Yes.
more.
So you will look for microvascular invasion and size of the tumor as well. All right, good. So then what is your next follow-up and what do you ask the patient to bring at that time?
We have to ask the patient to do a baseline thyroglobulin level. If it is a papillary carcinoma thyroid, we have to ask for a thyroglobulin and TSH as well. And along with that, and thyroglobulin antibody have to be asked for.
Correct. So why and when is this done? Did you say 6 weeks?
Usually we at 6 weeks we'll do one baseline level.
All right, all right. Okay. So and then after this you are going to characterize the patient, right? So say your TG and anti-TG everything is normal and the TSH is in normal range. What are you going to go for a radioiodine scan for this patient?
For this patient, it is required because its high-risk features are there. Clinically palpable lymph nodes is present, and the tumor is more than 4 centimeter. So we have to go with
so you are going for radioiodine scan. So what's the ideal TSH level that you need to obtain before radioiodine
more than
scan?
30. More than 30.
All right. And what are the 2 methods that you are going to use for that?
As a classical method, we will stop the thyroxine supplementation and we will follow up the patient. Next one is a recombinant TSH.
All right. And what are the absolute indications? I mean, what is a strong factor that will make you consider recombinant TSH over the classical method? Patient is already a hypothyroid patient, psychiatric symptoms, cardiovascular symptoms, and all right. Okay. So how do you give recombinant TSH?
You can give 0.9 milligram IM for 2 days. You can give, and after 48 hours, you can do this.
Correct. And so, what is the dose of your first diagnostic scan? How much do you give?
1 to 3 millicurie you can give for the diagnostics.
Correct.
Your last
And
question.
when do you take the diagnostic scan?
Following which, if there is any uptake in this after the diagnostic scan.
Check for the uptake. Like you're giving the dose.
Yes.
Then after 3 days only you're taking the diagnostic scan.
Yes.
Yeah. So now you have looked for the this thing and you have seen some like metastatic uptake is there. So sorry, there is residual tissue is there. What are you going to do next?
If it is more than 15% of the remnant tissue is present, we have to proceed with the radio-remnant ablation.
What about if it's resectable? Don't you check for resectability as well? If it's resectable, you can resect, right?
If it is resectable, we can go for a completion thyroidectomy.
So, and what is
Thank you very much. We need to stop. Thank you very much. Time is up. We have given 21 minutes to you. We'll move to the next presentation. GMC Trivandrum can make the presentation. Government Medical College Trivandrum, please.
Okay. Good evening, everyone.
Your time starts now.
Myself, Dr. Anana, Dr. Samuel, my teammates, Dr. Anana, Dr. Priyamada, and Dr. Sandeep. We are presenting a case of a 65-year-old female who's residing in Kollam, who is a retired nurse, educated till the graduate level, belonging to high socioeconomic status. She presented to us with a lump in the left breast for the past 3 months. It was insidious in onset, which gradually progressed to the present size over the past 3 months. There is no history of sudden increase in size of the lump, no history of associated pain, nipple discharge, or nipple retraction, no history of fever, trauma to the region, or skin changes over the lump. She did not give any history of lumps elsewhere in the body. There was no history of weight loss. There was no history of hemoptysis, chronic cough, or breathlessness. She didn't give a history of backache, bone pain, or there was no history of any headache, weakness, loss of consciousness, or seizures. And there was also no history of abdominal distension or any yellowish discoloration of eyes or urine. In past history, she is a known case of systemic hypertension and is on antihypertensives. There is history of type 2 diabetes mellitus, and she is on oral hypoglycemic agents. There was a history of carcinoma right breast, and she underwent modified radical mastectomy 14 years ago, and she was found to be BRCA1 positive, as it was mentioned by the patient. There is a history of adjuvant chemotherapy and radiotherapy as well, 14 years ago. There is no history of hormone replacement therapy, no known drug allergies, no history of childhood radiation exposure to the chest. In personal history, she follows a non-vegetarian diet. She has normal bowel and bladder habits. There's normal sleep and appetite. And there was no history of alcohol consumption or smoking. In menstrual history, her menarche was at the age of 13. She attained menopause at the age of 45. She has 2 living children. First childbirth was at the age of 25. Both children were breastfed till 2 years of age. And there is no history of oral contraceptive use. In family history, she is married, has 2 daughters. There is history of BRCA1 positivity in both daughters. Father passed away at old age due to natural causes. There was history of uterine malignancy in mother who passed away. There is also history of carcinoma of breast in sister's daughter, as well as in her aunt. And there is history of prophylactic mastectomy done in the sister's daughter. There is also history of carcinoma prostate in the brother.
Coming to general examination, after taking informed verbal consent, patient was examined in a well-lit room with adequate exposure from head to waistline in sitting, supine and bending forward position with arms by the side, arms elevated above the head and palpated in a semi-recumbent position in the presence of a female chaperone. The patient is conscious and oriented at the time of examination. Her ECOG score is 0. Her weight was 68 kilograms and her height was 164 centimeters with a BMI of 25.37 kilogram per meter square. Her hydration status was well maintained. There is no pallor, no icterus, no cyanosis, no clubbing, generalized lymphadenopathy or pedal edema. She was afebrile. Her pulse rate was 70 per minute in the right radial artery, normal volume, regular rhythm. There is no radio-radial delay or no radio-femoral delay. Her BP was 140/80 mmHg in right arm in supine position. Her respiratory rate was 14 per minute. Head to foot examination was normal. Coming to examination of breast, upon inspection, the right breast was post-mastectomy status with a healthy scar. The right axilla, there is no swelling palpable. Her left breast was pendulous breast with a nipple areolar complex directed outwards and downwards. There is no active discharge from the nipple, no nipple retraction. There is no engorged veins or any scars, sinuses, or any ulcers or any other skin changes over the breast. Inframammary regions were normal. Supra and infraclavicular regions were normal. There is no visible swellings in the left axilla. No bilateral upper limb edema. Coming to palpation, there is no local rise of temperature or tenderness over the lump. A lump of size 4 into 3 centimeter in the lower outer quadrant of the left breast, which is hard in consistency with an irregular surface and well-defined margins. The lump was fixed to breast tissue, but not fixed to chest wall, or not fixed to any underlying muscles or to the overlying skin. There is no palpable lymph nodes in the left axilla. There is no palpable left supraclavicular lymph nodes. Coming to systemic examination, the cardiovascular system was found to be within normal limits. Her respiratory system, air entry bilaterally equal, normal vesicular breath sounds. Central nervous system, there is no focal neurological deficits. Per abdomen, which was soft, non-tender, normal bowel sounds, no organomegaly, there is no any mass palpable, there is no shift in dullness. Per rectal examination, it was normal sphincter tone, there is no any mass palpable, normal fecal staining was present. Per vaginal examination, there is no any mass palpable. Skull and spine examination found to be within normal limits. Our case summary is, our patient, a 65-year-old female who is a known case of hypertension, type 2 diabetes mellitus, carcinoma right breast for which she had undergone modified radical mastectomy and was found to be BRCA1 positive, presented with a painless progressive lump in left breast for past 3 months. On examination, it was a 4 into 3 centimeter hard lump with well-defined margins and irregular surface fixed to breast tissue. There were no lymph nodes palpable in the axilla. The rest of the systemic examination was found to be within normal limits. Our provisional diagnosis is carcinoma left breast, T2N0M0, test stage of stage 2A.
Okay,
Your
so
opposite team, GMC Connecticut, can ask the questions. Your
that was
time.
a very good presentation with lot of things. So it's a clear-cut case of carcinoma left breast. So there might not be so much of differential diagnosis. So what are the risk factors that you identify in this particular case?
In this patient, the risk factors are a strong family history. Then,
Yes.
history of breast cancer in the past,
Yes.
and history of there is radiation exposure, radiotherapy to the chest, which is a strong non-modifiable risk factor. There's age is a important risk factor in this patient, as well as
female sex itself is a risk factor, 100
female
times.
sex and also BRCA1 positivity given by the patient. History,
the most
that is also very
important
strong.
risk factor here is the patient herself has history of carcinoma breast, and it's a BRCA positive. Okay, so in menstrual history, what all things, just going through what all things you will be asking for?
So we'll be asking for, we'll be looking for early menarche, late menopause, and the time period between the first childbirth and early menarche. The number of cycles is very important from early menarche to the first childbirth. Also, breastfeeding is also important.
Why breastfeeding is important?
Breastfeeding is known to be protective of
factor.
breast
So
cancer.
what?
Inadequate
How will you check for it?
breastfeeding,
If she's multiparas, if she's P3L3, you will look for a cumulative breastfeeding period. It's not a
Sure.
single one. It's cumulative. Okay.
Sure.
So in family history, how would do you know how much fold will it increase the risk of carcinoma breast according to the family history?
In first degree relatives, it is 3 times more. Relative risk is 3, and in second degree relatives, the relative risk is 4.
It's like in a first degree relative, if one person itself is present with a carcinoma breast, it's twofold, and if it is two persons is there, it's a threefold risk. And according to the age also, the risk will be increasing. So for that particular, if family history is strongly positive, what will you do? Is there anything for this case? Already it is done. So how will you proceed if family history is positive? What is the significance of that?
Strong family history, we will go for a gene sequencing, genetic mutation test, especially BRCA1 gene mutation, where
so you use some models for that?
See, once the patient is having a strong family history, there are lots of models that are having PRS incorporation, but the PRS models are not routinely recommended for genetic testing. It's the GAIL model, BRCA2 model, and all of those. In GAIL, greater than 1.7%. In this patient, we will first be testing the first degree family history.
So already this patient has BRCA1. So did you ask about any history of some surgeries that patient has undergone? Did you ask? What
there is a history of modified radical mastectomy in this
it's there. Yeah. Otherwise, she's BRCA positive, so
they will ask for any risk reduction
strategies that the patient has undergone. Bilateral oophorectomy, it could be a risk reduction strategies. Okay, just brushing through your history, you have asked about history of breathlessness, jaundice, abdominal distension, everything related to metastasis. So in this case, there can be metastasis because it can be an aggressive disease. So can you just give an anatomical route map? How does the mets occur to liver?
It is usually when the embryo reaches 20th cell doubling time, it achieves its own neovascular, own blood supply. That is when metastasis actually starts. So to the liver, it is usually through hematogenous spread. So through the blood, it goes to the tumor emboli. Goes,
you
tumor
know of
cells
any
go
other
to
method,
the
hematogenous, okay?
Through transdiaphragmatic method.
Yes.
So how does it happen? So it is going to go like transdiaphragmatic through the lymphatics over there. Then it is going to go to the umbilicus through the falciform ligament to the liver.
Okay, so it's basically from the saphe plexus, it starts in retrorectus.
Yes.
Okay, so you have asked about the importance of nipple discharge. You know what is the characteristic feature of nipple discharge you get in malignancy?
So we are going to get multiductal bloody discharge in malignancy, which is going to be sudden in onset.
So the word is spontaneous. You will get a unilateral spontaneous discharge. Mostly a serous is more favorable than a bloody discharge. A serous discharge will be more favorable. Okay. Now, you have said that you have examined this particular patient in different positions. So what is the ideal position you will examine the breast?
Ideal position is sitting. Patient is in relaxed state. Arms
Sitting
by the
anything
side of the
extra?
patient.
Can you modify?
Arms by the side of the patient or arms elevated above the head.
Sitting, you have to do a 45 degrees semi-recommend. So the ideal position is
45-degree recommended is the ideal position.
ideal position. Why is it an ideal position? Why is it an ideal position?
If it's lying supine, if the breast is so pendulous, it may fall sideways. And also,
according to the meta-analysis in literature, it says an ideal position is 45 degrees semi-recommend. It's because there is an even distribution of the breast tissue in that particular position, so that you can examine all the areas of the breast, all quadrants, as well as the axilla when the hands is up, and also inframammary crease.
So, what is the technique you use to palpate the breast limb? What are the techniques that you know of?
What are the methods of palpation?
There's a dial clock method. There is zigzag method. The most important thing is that you go systematically and make sure that every part of the breast is examined.
And with the tip of the fingers with a flat hand.
fingers in the palm.
In a dial clock, how will you do? It's a dial clock. So how will you do? It's from peripheries to center or center to periphery?
It is from center to periphery. You go from the nipple and go radially remove. And then you like circumferentially.
It's like nipple areola complex. You have to dial a clock. Okay, so it's just like clock moving in a clockwise direction from nipple areola complex to periphery. Okay.
So your case doesn't have a skin tethering. If your case has skin tethering, will it affect the stage? What is the stage?
No, it will not affect the stage.
So what are the features to upstage the skin involvement?
In case of any purity orange appearance and also any skin ulceration and
presence of
satellite nodules.
What are these satellite nodules?
Satellite nodules are
these are nodules that is present well away from the tumor site, but there is a normal skin in between, and it should be macroscopically identified. And according to the recent NCCN guidelines, if it is microscopically identified in the absence of a purity orange or a ulceration, you cannot consider it as a T4B disease. Okay, so this is an early breast carcinoma.
So what are the things that you are gonna examine while by raising the hands above the shoulder?
By raising the arms above the shoulder, if there is any visible lump in the breast, it will become more prominent. And also, if there is any skin tethering or puckering, it will be more visible. And also, if there, we can examine the axilla. We can examine the lymph node
as well as the inframammary.
All the occult things will be more manifested.
Yes. So now you have done a clinical examination. Your diagnosis is an early breast carcinoma. So how are we going to proceed further?
Again, since we'll start investigations, which includes a triple assessment, out of which the triple assessment clinical examination part has already been done. And since we're already getting a breast lump, it is better in all settings we go for a mammogram directly. There is no need for a screening. We are getting a clinically palpable breast lump. We will be going for a bilateral mammogram.
Yes,
and
we'll
once
be
that
going
is
for a
done,
bilateral mammogram.
along with a sonomammogram that will help in assessing the axillary status as well. Once we get to that status, again, then we'll go for a biopsy, which is the histopathological diagnosis will be followed.
Okay.
Now,
yes. Now, okay, the triple assessment is done. Now we have like you are going to do a bilateral mammogram. So this is a patient is having a
left already, right MRM is done.
Yeah, I was talking about in the general setting. For this patient, again, we'll go for a mammogram. Also, since she comes as a high risk patient, we'll prefer a CT for this patient. She comes under the high risk.
It's anything else? CT or anything?
We'll
BRCA positive?
CT because in this patient we will be considering neoadjuvant treatment as well. And since it's it's a second breast recurrence, and even though it's a 14 years gap, it is always better to rule out distant metastasis.
Will you do an MR mammography? It's a BRCA positive.
See, MR mammography for a BRCA positive patient in the screening setting is very, very important. If I'm going to use this for resist follow-up, then I will consider an MR mammography.
For resist follow-up, we have to consider MR mammography.
So what are the features of significant lesions on mammography?
Again, a significant lesion on mammography will usually show microcalcifications. There will be stellate lesions with spiculations. There will be a loss of architecture, significant loss of architecture, and increased density as compared to the surrounding tissues. Also, suspicious microcalcifications.
Okay, what is Bidard's foray?
Is low suspicion of malignancy. There is 5 to 10% of malignancy risk.
It's
2 to 10, sorry. 2 to 10%. Yeah.
Okay. Do you know any of the, can you do a molecular subtyping by mammography? Just a question of interest.
We are
So
not
while
You can do.
you can actually do a molecular subtyping with the help of mammography. For example, in case of a TNBC, triple negative breast cancer, it will be based on the tumor roundness score. We'll have a more unifocal and round tumor, and other cases
For
like
luminal
luminal
AST
LV,
also you have different architecture so that you can identify. It's just a way to identify, but anyways you need an IHC.
So in case of an early breast carcinoma, does this mammography tells you any other thing other than this malignancy part is concerned? Apart from that, considering the management part, the BCS part, does this mammography helps in you any ways?
In this patient, we are anyway will probably not consider BCS, but definitely for looking for multicentricity and multifocality, we will be mammography will be helping in that region. Also,
So,
diffuse
why
microcalcification.
don't you consider? Okay, it's okay. Why don't you consider BCS for this patient?
The patient is old. MRM will be the first choice
Is
that we
old
will
age
be.
a contraindication for BCS? What are the absolute and relative contraindications?
So the absolute contraindications are multicentric disease. See, for radiation, first, any contraindication to radiation, the absolute contraindications for radiations are pregnancy and ATM mutations, and there are relative contraindications. Then, according to the NCCN, absolute contraindication is also BRCA1 is listed as an absolute contraindication. Then there is
this multicentricity and multifocality nowadays is not considered as an absolute contraindication. You can still go for an BCS. But for this case,
according to the latest NCCN guidelines,
BRCA is a relative contraindication.
Absolute contraindication.
You have 8 minutes more.
Okay, now moving on further, you have done your radiological investigation. What will be your next investigation? What will you do next?
Again. See, once we've done with the radiological investigation, we'll definitely go for a histopathological examination, that is biopsy. In any setting, the first biopsy that we'll do, ideally right now, it is preferred. What is preferred is a core needle biopsy.
Yeah,
Earlier,
so you will
used to be
you
done,
should
but then
be,
we'll go for a core needle biopsy.
yeah, you should be actually doing an image-guided core needle biopsy.
Image-guided core needle biopsy. There are actually various techniques for core needle biopsies. We'll prefer an
Yeah, so
image-guided.
next, is there any condition that you know of where you will actually do an excision biopsy?
Again, if
After
a lesion is
doing a
if a lesion is less than
corneal
if a lesion
biopsy?
is less if a lesion is less than 2 centimeters in size, and if repeated true cut biopsies have given you a negative result, it is ideal to go for an excision biopsy. Also, in case of a breast cyst, if there
Any
are
other
multiple
conditions that you
aspirations,
know?
if there are
Yes, there is an ADH is considered one of the indications for excision biopsy, because 20 to 30% of the cancer can come on DCIS.
Okay.
Cellular fibroadenoma is an indication. In case you're sampling a radiological abnormality and you take a true cut and the post test is negative, then also you can go for an excision biopsy.
Then there are also papillary lesions and radial scar and such things.
Yes, and also discordance. When you're taking a true cut and then there is an imaging and discordance.
Okay, now you have gotten your HPR report. You have gotten a histopathological report as invasive ductal carcinoma of no specific type, and your all-red score for AR is 6+, and for PR is 5+, and HER2 is 3+. So how will you proceed with this case?
So since the patient, we have got an invasive ductal carcinoma, right? If they had heard that, right? So and it's HER2 enriched as well. So definitely I'll be considering, I'll be discussing this in an MDT, since the patient is also high risk, and I will be considering a neoadjuvant therapy in this patient, which can be either you can stagger the trastuzumab and pertuzumab in between the surgery, or it can be given.
What is the chemotherapy? So in HER2 enriched, what is the chemotherapy you give?
So we give it the TCHP, which is trastuzumab, pertuzumab.
If it is a triple negative breast carcinoma, if it is a TNBC?
Even a triple negative breast cancer, we will again be going for ACT, adriamycin.
How many cycles will you give?
Cyclophosphamide. What?
Taxane, cyclophosphamide, adriamycin, and cyclophosphamide. 4 each, and 8 cycles total you will be giving.
Cycles, yes.
So what is the precaution? What is the precaution that you will take before doing an NACT?
For this case, if you are proceeding, it's an early breast carcinoma. If at all you are proceeding with the BCS, what precautions will you take?
I will be, when I'm taking a true cut itself, I'll be trying to clip the patient with the true cut.
Okay,
so that if it is a complete response, I will be able to accordingly plan the surgery.
Or but you can do tattooing. You can do tattooing.
Yeah, tattooing as well, yes.
Is there any new drug that has been introduced for your case, if BRCA positivity?
It's a BRCA
Yeah, so
positive.
as an adjuvant, we can do PARP inhibitors, olaparib can be given, but if you're saying it's HER2 positive, then olaparib cannot be
It
given.
cannot be. If it is HER2 positive, what will you give as an adjuvant therapy?
Trastuzumab and pertuzumab will
What
continue
you
for
call
1
that
year.
trastuzumab? It's usually in adjuvant therapy. Adotrastuzumab. Yes, of course. Yes, good.
Trastuzumab exmestin or something.
Okay. It's okay. TDM1. We call it as TDM1 as adjuvant therapy. For 1 year, you have to give it. Okay.
Yes.
So now you are done a breast. Suppose if you are done a breast conservation surgery for the patient, and if the margins are coming as positive, so what are you going to do next?
So the patient is having a breast conservation surgery. Margins are going to be positive. Just with the margin positivity, first I will be considering re-excision for the patient. Second is, again, the pathology is also important. If I have to plan chemo and radiotherapy
What
for
is
the
margin
patient.
positivity?
What is margin positivity in BCS?
So see, anyway, we are looking for no incon tumor. If there is incon tumor, it's margin
What is
positive.
What is the margin that is required in the case of DCIS?
2 mm margin.
2 mm margin.
Yes.
Yes, very good.
Yes.
So in this case, if at all you are counseling, you have to counsel the patient after your MDT. You have decided and you are counseling. So what all things you will counsel? What all things you will tell this patient?
First I'll be counseling the family about the MRM and the post-op care that is required, the requirement of chemo and RT and all of those things. I'll be counseling this patient for the family members that they might also have to consider genetic testing. Since already she's BRCA1 positive, there will already be the familial pathogenic variant that will be identified. So it will be much easier and a restricted and a cheaper genetic test that will be available for them. So they can do that as well. And then
we'll be basically going for an MRM. So let's imagine that this patient wants a BCS. Let's imagine she hasn't undergone MRM on the opposite side. So she wants in BCS. So what all things you will advise?
So the patient will have to be advised that there will be a requirement of post-op radiation for sure. Then there will be regular follow-up that will be required.
Be a very stringent follow-up that the patient should have. Yes.
Yes. And then the patient can consider, in BRCA1 positivity, the tamoxifen and everything is not being shown to actually reduce the risk as much. So I will be making her consider but since she's already going for a BCS, mastectomy is not an option.
You also tell the risk of recurrence for this case.
Yes.
That's why though it is 2 to 3%, you have to just tell them there is risk of recurrence also. So, so what all things you will consider as an adjuvant therapy post-operatively? And by the way, how will you deal with the axilla if you are going to do a BCS?
So this patient is having an early breast cancer with an N0 nodes. So I will be going for a SLNB in this patient in an ideal setting.
So if the USC shows a lymph node, what will you do?
If USC shows a lymph node, I will be going for an FNAC.
Yes, USG got FNAC. If it is negative, you will be going for?
If it is negative, I can see depends because it's in a high risk patient. I can also consider a guided true cut in this patient. But again, an SLNB is positive even if a USG if FNAC is negative and a USG positive node. Yes,
you can do.
Again, I can go for a dual tracer SLNB.
Okay,
but since I'm giving neoadjuvant in this patient, while taking FNAC itself, I will be marking. I'll be putting a radio tag in there. I can use a radio seed. So many ways are there.
What is it called?
I don't know what it's called.
Targeted axillary dissection. You can clip pre-operatively and then the patient will undergo for a chemotherapy and post-operatively. You can do a targeted axillary dissection.
Your last minute.
So in this case, how are you going to follow up this particular case? If you have done a BCS and if you've done an MR. If you've done a BCS, how will you follow?
So if I've done a BCS, the patient first I'll be following it up first for the post-op wound visit, 2 weeks check for any complications, seroma and all of those things. Then I'll be referring the patient as soon as I get my HPR. I'll be putting the patient forward in the radiation
adjuvant therapies and all. But you are going for MRM. So post MRM, what are the indications for giving the adjuvant therapies? What all things you will do?
So for adjuvant radiotherapy post MRM, any premenopausal patient with 1 to 3 positive nodes, any patient with 4 positive nodes, a stage 2 disease with lymphovascular infiltration greater than 20% node positivity, or margins are positive, inadequate level 1 or 2 dissection is done.
Margins
then back biology.
MRM, you shouldn't be having margins positive. Okay.
Your last
It's okay.
question. Your last
Sure.
question.
Yes.
So what are the complications of a modified radical mastectomy?
First, with respect to the breast, there will be seroma, there can be reactionary hemorrhage, there can be wound infection, that is the early complications. And with respect to
So
the
if you're going
axilla,
with a BCS, do you know what is oncoplasty?
yes, it is the application of plastic surgical principles
So
in breast cancer
so
surgery
it's a
without
very small
compromising
one.
on the
What level of oncoplasty will you prefer?
level 1
Yes,
oncoplasty,
very
20,
good.
less
It's a
than
level 1
20%.
oncoplasty you can
Thank
go with.
you.
And you have done with the ptosis.
Thank you.
Thank
Thank
you.
you, Dr. Or team members from Calicut.
Thank you, sir. Thank you. Thank you.
Thank you from Trivandrum as well. We have quick comments of 1 minute each from 3 examiners, how they felt, and their general assessment. It's not about marking or anything. Some advice to the students. Let me have first Prabhu Yogi.
A very good evening to you. I must say that I'm really impressed, and you would be making much better examiners than what I am at present. So, all of you, in fact, all the 8 of you, are brimming with knowledge, and you did a very good job. But our job is to assess the examiners, not the level of knowledge. So, we are watching you from the point of how you examine your students. So, but excellent, both of you. It's very difficult to judge who is better than whom. But yes, we have some criteria, and we'll come to a decision later on. Thank you very much.
Thank you, Dr. Prabhu Yogi.
Thank you.
May I
Thank you,
have
sir.
Dr.
Thank you, sir.
Vikram Karthik? May I have Dr. Vikram
Yeah,
Karthik?
yeah, I echo the sentiments of Professor Nyogi that the same thing that they are brimming, so much brimming with knowledge that I was wondering that in 20 minutes how they could ask so many questions on both the sides, and the people who are listening to them. I'm sure this is partly closed session, but it's an open session. I'm sure a lot of people
We
will
are
benefit
televising
from
it
so
to
much of
YouTube, sir.
knowledge.
We are televising it
Acha,
to
they are on
YouTube.
YouTube. Okay, okay,
Yeah,
okay.
yeah.
Then it
Please
is
go
good.
on.
Yeah, that will be
Yeah,
because
yeah, yeah.
so much of so many questions and so many answers. So it will be excellent for everybody to learn. But as you said, yeah, we are examining the examinership of the students. So we'll see how it goes, and later on we'll take the decision. Thank you.
Thank you, sir.
Thank you, sir.
Last but not the least, Dr. Abhay Dalvi.
Yeah, thank you. Both the other examiners have talked very nicely, but I am going to be very critical about all this. Both the presentations were good, but biased. Right in the history, the diagnosis of malignancy was told. Why it was told, I do not know. It only comes through examination that you come to a diagnosis of malignancy on either side. That's my point number 1. Point number 2, I felt that it was more of a clinic rather than an examination. And that's why I go on record to say that all 8 of them can be very good teachers. That's my personal opinion, that they were supporting each other, both the teams. They were competing against each other, it's okay, but they were supporting each other. Their nodding of head, etc., was very good. The third part, I felt at MS level examination, there were too many advanced questions were fired by either team at each other, which I, as an examiner, retired now, I know, retired by universities also, but these are not the sort of questions which are expected. They are expected in surgical oncology group and not at MS general surgery group. So you should go with a conviction when you go for an examination. Let's talk of the first case. Let's talk. I have 2 minutes time, Santosh.
Just about a minute, sir.
Okay,
Because,
fine. First case also, lot of additional questions were asked. At MS level, lot of simple questions are asked. Right at the start, I would have asked about benign thyroid swelling and diverted you and just scuttled you on to treatment of malignancy, which you are very well, well read. Same thing happens on the breast side. This is a learned lady. She's a nurse by profession, has thought of MRM as the first choice, not undergone reconstruction. There is no question of telling her you go undergo breast reconstruction and then go into this. I don't think that could have been a correct answer. My sincere request to all the students who are listening is very simple. Think of you or your own very close relative of the patient when you are answering an examination. That will give you better thing. Thank you, so Santosh, for inviting me.
Thank you very much. Thank you very much, both the teams.
Thank you, sir.
Put up a very good show. And I will move to the second semi-finals with the Government Medical College Kottayam making the first presentation and Lutz making the second presentation. Medical College Kottayam, you can share your
Good evening, sir.
slides.
Shall we share the slides?
Yeah, please. All the best to both the teams.
Santosh, you want me to wait?
Yeah, this is also yours.
Okay, fine. I'll wait. No problem.
Both
Sir,
the
can you
cases
see
are
your
handled by.
presentation?
Yeah, both the teams, both the semi-finals are marked by you.
No problem.
Shall we start presenting, sir?
Yeah, please. Your time starts now. 10 minutes.
Good evening. Presenting the case of Mrs. X, 60-year-old female, hailing from Chairtala, who is a homemaker. She presented with a lump in the left breast for the past 4 months. Patient was apparently normal 4 months back when she noticed a swelling in the left breast while bathing, which was initially small in size and rapidly progressed to the present size. The swelling was not associated with pain or fever. There is no history of any trauma to the breast. There is no history of nipple discharge, retraction, ulceration, or destruction. There is no history of any skin changes in the overlying skin. There is no history of other swellings in the opposite breast and axilla or neck or anywhere else in the body. There is no history of edema in the left upper lip. No history of any recent onset, continuous bony pain, breathing difficulty, pleuritic chest pain, persistent headache, seizures, abdominal pain, distension, or jaundice. Past history, there is no history of any surgeries in the past, no history of any breast lump in the past, no history of type 2 DM, hypertension, COPD, CAD, CVA in the past. There is no history of any OCP or hormone replacement therapy use. Family history, there is no history of any breast or other malignancies in her family. Personal history, she consumes non-vegetarian diet, she has normal sleep and appetite, normal bowel and bladder habits. There is no history of smoking, alcoholism, or the use of any addictive substances. Menstrual and obstetric history. She attained menarche at 14 years of age and menopause at 52 years of age. Her cycles were regular with 4-day bleeding cycles and 28-day duration. Obstetric history, she is para 2 live 2. She had full-term normal vaginal delivery. Age at first childbirth was 24 years and second childbirth at 27 years. She has breastfed both children for a cumulative period of 4 years. She has underwent postpartum sterilization after the second child.
Examination. After obtaining consent, patient was examined in a well-lit room with adequate exposure in the presence of a female bystander. Patient was conscious, well-oriented in time, place, and person. Her height was 155 centimeter, weight was 55 kilograms with a BMI of 22.8. ECOG score was 0. There was no pallor, icterus, cyanosis, clubbing, edema, no generalized lymphadenopathy other than the involved axilla. Her vitals examination were normal. Examination of the breast. She was examined in sitting, semi-recumbent and recumbent position with hands raised, hands pressed against the waist, hands by the side and bending forward. Right breast and axilla examination was normal. Inspection. Left breast. Left breast appears larger than the right breast. There are no dimpling, tethering, dilated veins, sinuses, or visible scar mark. No ulceration or skin nodules. Nipple areolar complex. Left nipple is at a lower level than the right. Both nipples are symmetrical, normal in size, shape, surface, and position. No flattening, retraction, no active discharge. Areola had no cracks, fissures, or ulceration. Inframammary area was normal. Supra and infraclavicular region was normal. No edema in the left upper limb. No visible swellings in the left axilla. This is the picture of our patient. Palpation of the left breast. No local rise of temperature or tenderness. A lump of size 6 into 6 centimeter. occupying both upper and lower outer quadrants with a globular shape, hard consistency, irregular surface, and well-defined margins. It is fixed to the breast tissue, but not fixed to the pectoralis major or chest wall. Lump is fixed to the skin with odd orange appearance on palpation involving 1 in 1 centimeter skin overlying the tumor. There is no nipple discharge. Examination of the left axilla. Multiple hard, fixed, non-tender nodes, largest 2 into 2 centimeter in the pectoral and central group of lymph nodes were involved. Supra and infraclavicular lymph nodes were not palpable. This is a schematic representation of our patient's lump. Systemic examination. Musculoskeletal system was normal. No spine tenderness was palpated. Respiratory system, bilateral normal vesicular bed sounds. Per abdomen, soft, non-tender, no organomegaly. CNS, higher mental functions were normal. There were no focal neurological deficits. S1 and S2 were heard in no and with no murmurs. Per rectal and per vaginal examination was normal. Summarizing, 60-year-old postmenopausal female with no known comorbidity presents with a painless lump in the left breast for the past 4 months. On examination, a lump of 6 into 6 centimeter involving both outer quadrants of the left breast, hard in consistency, fixed to the breast tissue and skin, but not to the underlying muscle or chest wall. Multiple hard fixed pectoral central group of lymph nodes were present with odd orange appearance and multiple hard nodes in the left axilla with the largest measuring 2 into 2 centimeter. I would like to come to a diagnosis of carcinoma left breast T4B N2A M0 stage 3B locally advanced breast cancer.
Team Lutz, you have the next 10 minutes to question, sorry, 20 minutes to make the questions.
It was a good presentation. Why do you say that? Why do you say that it's a locally advanced breast cancer from your history and examination?
My patient has breast cancer because the lump is hard, fixed to the breast tissue, fixed to the skin, and has poured orange appearance with fixed hard lymph nodes. This comes to a diagnosis of malignant breast. It is T4. This is locally advanced because of the staging. The size is 6 into 6 centimeter with infiltration into the skin. That is T4B. And nodes are fixed and okay, that is N2. So both comes to locally advanced breast malignancy.
Yeah, since you told first you derided malignancy, you can also tell because of your patient's age, female sex, all that also can be included. Okay, good.
Okay, your condition is painless breast condition. Can you say anything, any painful breast condition?
Painful breast conditions mimicking malignancy is inflammatory carcinoma breast. Sorry, painful breast condition with malignancy.
Painful breast condition.
It can be inflammatory breast diseases like acute mastitis. It can be non-lactational mastitis like chronic granulomatous mastitis, where there can be a lump along with pain, and even the pudgy orange appearance and axillary lymph nodes can be there.
Also, when carcinoma infiltrates the skin or the parietal pleura, there will be pain.
Any breast abscess can produce pain.
Yes, fibroidosis also can produce.
Breast abscess can produce pain, and even simple cysts end up with cyclical mastalgia.
Okay. So you have asked regarding intake of oral contraceptive pills and hormonal replacement therapy. Do you think that oral contraceptive pills is a risk factor in current era?
No, not at the current era, but the high dose estrogen taken for a more than duration of 5 to 10 years is considered as a high risk for breast cancer.
Actually, in 1960s and 1970s, postmenopausal complaints were treated with hormone replacement therapy without knowing its comorbidity side effects.
Currently, we have combination pills with low dose estrogen and progesterone, so they are not identified as risk factor anymore.
Yeah.
Okay. Now you already mentioned it. Can you tell what all you have to ask in your menstrual and obstetric history and why you are asking all those things?
There are important identified risk factors in the menstrual and obstetric history, starting from menarche. Early menarche, where menarche before 11 years of age is considered to be an identified risk factor, as well as late menopause, that is menopause occurring after 55 years of age. And that is mainly because of the increased increased number of estrogen and progesterone cycles that the patient is getting exposed to, which increases her risk. As well as there is importance of lactation, as well as age at first childbirth. Age at first childbirth, if it is less than 20 years of age, she has a protective effect. And age at childbirth after 35 years of age is considered to be a risk factor. Then multiparous women definitely have less risk when compared to nulliparous women. And also the cumulative period of breastfeeding. Cumulatively, if she has breastfed her child for more than 1 year of age, she definitely has a protective effect.
Okay. There is also, you can also tell one hypothesis, like Codman's hypothesis. You rightly told early menopause, menarche and late menopause. No, so the anovulatory cycles are there and hyperestrogenic states are there. That is called Codman's hypothesis. That also you can mention. So, okay.
Actually, you have said that age at early first childbirth is 35 years. For Indian population, it is usually considered as 30 years for Indian population, and whereas 35 years is most generally described for Western countries. So in case of an Indian population, age at first childbirth is usually 30 years, and lactation up till 1.5 years also can be protective in case of a breast cancer.
What is the importance of family history in this case?
There are certain 5% of the malignancies are familial and hereditary. There are more familial malignancies than hereditary malignancies. In hereditary malignancies, BRCA1 mutation, BRCA2 mutation, PAL mutation, Leaf-Romani syndrome,
P10-Cowden syndrome,
P10 mutation, Peutz-Jeghers syndrome are all risk factors. Also, breast cancer runs in families as well, without a susceptible specific group.
Also, if there is a first degree relative with breast cancer, the relative risk increased by 2 folds.
Yes. Can you say some examples for BRCA1 mutations and BRCA2 mutations?
The cancers. The cancers.
Yes, BRCA1
cancers?
Malignancy chance of 70 to 80%, with ovarian malignancy and also colorectal malignancy and peritoneal carcinomatosis. BRCA2 will have breast malignancy, male breast malignancies, ovarian malignancies, prostatic and pancreatic malignancies.
Other malignancies are most common with BRCA2 mutation when compared to the BRCA1 mutation.
The pancreas, the prostate, and the male breast cancers are more common in BRCA2 compared to BRCA1.
Can you say what is the mechanism of purity orange appearance?
It is due to the subcuticular lymphatic obstruction. Cutaneous lymphedema occurs, and the hair follicles that is attached to the dermis gets deepened, and there will be an appearance of orange skin. This is due to tumor emboli deposition in the lymphatics.
Yes.
You're saying that there is no tethering in your patient. What do you mean by that?
Tethering is infiltration of the Cooper's ligament. Usually, when you move the lump, once you release the lump, some kind of dipping or tethering will be seen.
So you put tethering in the inspection, no?
Tethering and skin fixity both same.
In your examination, you put in the inspection.
Tethering is due to the infiltration of the Astley-Cooper's ligament, where the skin infiltration or skin fixity is due to the infiltration of the malignancy directly onto the skin.
What are the other characteristics of skin infiltration that you can determine by examination?
Skin ulceration, fungation, satellite nodules, and purity orange appearance.
Skin edema and erythema also can be considered as skin infiltration in case of an inflammatory carcinoma.
Inflammatory carcinoma involving more than 1/3 of the breast surface.
You mentioned per abdomen examination in your findings. No. What is the importance of looking at per abdomen? What all will you find?
Metastatic is what we're looking for. Most commonly, there is abdominal distension, shifting dullness can be there because of ascites in abdomen examination in liver metastasis. Okay. Secondly, Krukenberg's tumors, especially in premenopausal women. Krukenberg's tumors, there can be
postmenopausal, right? Postmenopausal.
Our patient is a postmenopausal.
Our patient is postmenopausal,
but here we don't have.
Krukenberg's are seen in postmenopausal women.
Premenopausal.
Premenopausal women.
Premenopausal.
Actually,
can it be seen in postmenopausal?
Also, very rarely.
Yes. Yeah, rarely, but it's seen also. What is the mechanism of Krukenberg's tumor? How does it spread?
Actually, it is due to the transcelomate spread of the breast cancer into the active ovary. Due to the multiple ovulation, there will be insults to the epithelium of the ovary, causing the tumor cells to get attracted and deposit. It usually presents with multiple large deposits in bilateral ovary.
Transylvanic spread was there. It was actually an older concept. Now, hematogenous spread can also be explained by and hematogenous retrograde spread is also explained in Kruger-Buck tumor. So it is seen in postmenopausal ladies also.
Can you hear us? Are we the one who was stuck?
No, Kottayam seems to have yeah, now they have come back. Yeah, go on.
No, sir. Can you hear, sir?
Sir, can you
Yeah.
hear?
We can hear you.
Yeah, go ahead.
You
Go
have,
ahead, please.
yeah, you have examined for axillary lymph nodes. While examining the axillary lymph nodes, let's say that you have come around with a patient who is having contralateral axillary lymph nodes palpable. So, what do you infer by this contralateral axillary lymph nodes positivity?
We will consider it in the setting of carcinoma as a metastatic one, or else a reactive lymph node.
No, you cannot say if it is a metastatic or a reactive lymphadenopathy without examining the contralateral breast first. You should always examine contralateral breast because there can also be coexistence of a contralateral primary, which can cause primary lymphadenopathy in the contralateral axis. Do you have any idea about Chaudhary criteria?
Chaudhary-Wells criteria is used to assess if the second breast, if the lesion in the second breast is either due to the primary metastasis or a second primary. Usually, if it is a second primary, the grade would be different. The tumor IHC will be different. Also, there will not be any evidence of any distant metastasis. Also,
there will be an in situ component that can be demonstrated in the tumor.
Yeah.
In the absence of any other metastatic disease, if this are there, it is considered to be a second primary.
Next, how do you manage your case?
First, we will be going with the triple assessment of the patient. After clinical examination, we will be proceeding with the mammogram. And according to mammogram, after mammogram, we will be doing a core-needle biopsy of the patient. And according to ERPR status and according to the HPR report, ERPR says, then we will be staging the patient. After staging, we will be offering the patient a multidisciplinary team.
Yes.
Okay. You told mammogram. What are the different views in the mammogram?
There can be MLO view, mediolateral oblique view, or craniocaudal view, CC view.
Then there are additional views like 90 degree lateral view,
Cleopatra
Cleopatra view, and also
Magnification views, mediolateral views.
Yes, spot 90-degree cleavage view.
Spot compression and stereotactic is also in our.
Yes.
We are now
there any
halfway through the month.
advancement?
10 minutes more.
Yeah,
10 minutes more.
Are there any advancements in mammogram? Like other than conventional mammogram, can you do anything with the mammogram?
Yes, we have now 3D mammogram, which is also called as tomosynthesis. We also have contrast enhanced mammogram, contrast enhanced X-ray mammogram, through which we give iron contrast.
Let's say that your patient is an inflammatory carcinoma and your patient is having severe pain. Can you proceed with mammogram in this patient?
No, in severe pain, we have to avoid mammogram for the symptomatic relief.
Because the mammogram itself is a painful investigation
because of compression in the breast plates.
You should go with an alternate investigation like ultrasound. Ultrasound can be done to look at the breast characteristics and lymph node. Let's say that your patient, after doing mammogram, how do you proceed?
Ultrasound guided through-cut biopsy is the next best procedure to be done.
What's the advantage of through-cut over FNEC?
Yes. It is easier to
Can't hear you.
Can you hear us? Can you hear us?
It's okay now. It's okay now.
Yeah.
It's okay.
Continue.
Please continue.
Hello, can you hear us? Can you hear us?
Yes.
IEP can be taken from ER positivity to new positivity. And sir, can you hear us?
Yeah, we can hear you.
Index, mTOR mutation, NIBC mutation, S phase.
Also, since it's a locally advanced carcinoma breast, we need a pathological tissue assessment. If the patient, after undergoing a neoadjuvant chemo, if the patient has pathologically complete response, we don't have a tissue for a further examination. So we need a core needle biopsy.
Yeah, in situ in vivo chemosensitivity. You can just put it together. Okay.
Do you want to do anything along with doing through-cut biopsy for this patient?
Tattooing can also be done, or you can insert clips, because if ever the patient becomes completely responsive, we may not know the lump may have gone.
Where the lump is situated.
Yeah. Do you want to take FNAC or through from axilla?
Yes.
We will take
FNAC.
Yeah, you can take FNAC, and while doing FNAC, you can also put clips or tattooing to the axilla for later targeted axillary dissection.
So when you're telling your management, you can tell the FNAC of the axillary node also, since you're getting an axillary. Okay. So what is the neoadjuvant chemotherapy that you're planning to give to your patient?
4 cycles of that's according to the HBR report. If the
generally the thing that is prescribed is 4 cycles of adriamycin cyclophosphamide. Adriamycin is given 60 milligram per centimeter square. Cyclophosphamide is given 60 milligram per centimeter square 3 weekly for 4 cycles, followed by taxanes. Paclitaxel or docetaxel can be given. Paclitaxel 175 milligram per meter square for 3 weekly cycles are given for 4 cycles. If the patient is HER2 positive, I would like to add trastuzumab and pertuzumab. If we are giving trastuzumab and pertuzumab, we should give with the taxane cycle, and we should give docetaxel instead of paclitaxel.
Okay. So you have done the IHC, and you have got your IHC report, and IHC report gives us HER2 2+. How do you proceed in this patient?
HER2 positive, we will be saying
HER2 2+.
2+ is equivocal. Now we have to go with the fluorescence into hybridization with a single probe. With a single probe, if it produces less than 4 copies, then it is negative. If it produces more than 6 copies, it is positive. If it produces 4 to 6 copies, again we have to do fluorescence into hybridization with a double probe. If with a double probe, if this is less than 2, then it is considered as negative. Equal to or more than 2, then it is positive.
So you have got FISH also equivocal results. So how do you proceed? You can always proceed with repeat biopsy. You can always proceed with the repeat biopsy at the other site, and then you can repeat the IHC. Then even if you still get the 2+ or equivocal result, then you consider it as a negative HER2, or else you can go with the genomic assess. Do you know any genomic assess that can be done for breast carcinoma?
Oncotype DX and mama print can be done. Oncotype DX and mama print. 21 gene is existed in oncotype and 70 in mama print. This is usually done when chemotherapy.
Just name the.
Okay. After how many cycles of chemotherapy do you assess the patient?
2 cycles of chemotherapy, we'll do an assessment for the response, and that is done by the RECIST criteria. What is the response assessment for the response assessment to chemotherapy in solid tumors? And in the RECIST criteria, complete responders, there can be progressive disease, stable disease, or partial responders. Complete responders, there is complete absence.
Understood. If your case you're getting a progressive disease or a stable disease, then what is your next management?
We'll be going for upfront surgery.
No, alternative chemotherapy regimen should be tried at first.
Second line of chemotherapy can be given, or if it's operable, you can do surgery. That's also right, but second line of therapy can also be given. Okay, good.
You on RECIST criteria, you got it's a case of showing complete response. So how do you proceed in this patient?
This is actually a good news. Complete pathological response means the prognosis of the patient is good. So we have to complete the entire cycle. 8 cycles of chemo has to be completed, followed by surgery.
This patient can be now given the option of either conservative surgery or a radical surgery.
And
in
also your case, what are you preferring? You're giving the options of both BCS and MRM in your patient.
If it is complete response.
Okay, so if you're doing a MRM, like what is MRM? What is modified radical mastectomy? Can you just explain what is it? What structures you preserve and what structures you take out?
In modified radical mastectomy, the entire breast tissue involving the overlying the skin, the nipple areolar complex, as well as the pectoral fascia is being removed, along with the axillary lymph nodes level 1, 2, and 3. Then the structures preserved are the intercostal brachial nerve. Then we have the pectoralis major and minor muscles are preferred when compared to radical mastectomy.
You should also remove axillary tail of fence, and pectoral fascia should also be removed along with the breast tissue.
And since you're telling MRM, so preservance, you can also tell the other axillary clearance what you're preserving. Thoracodorsal pedicle, long thoracic nerve, axillary, and all that also you can include. So it will be a complete answer. Okay, so if you're doing a bone scan, what are the did you not mention the stage? What all investigations you're doing for staging, right?
Right about staging. Further questions.
Staging investigation. What all the staging investigations that you need?
actually we can go two wings or two thoughts of ideas are there. Either you can go for a PET CT directly, or you can go for a
contrast enhanced CT of a chest and abdomen pelvis with a bone scan.
Yeah, okay.
So you have done the bone scan and you have found that there are bony metastases. How do you manage the patient with the bony metastasis?
Now it becomes a metastatic disease. Number of mets is important. Oligometastasis. In case of can you hear us?
Can you hear us?
Excuse me. Hello, sir. Are we audible?
No, you are audible. There seems to be
Even before going for surgery, you have found out the patient is this. Sir, are we audible?
Go ahead. Go ahead.
Yeah, you have done the bone scan and you have found bony metastasis even before upfront surgery. So how do you proceed in this patient?
In one thing is there is a concept of oligometastasis. If there is less than 5 metastases in two or less than 2 or 1 organ, then it is considered to be oligometastatic. Then we'll proceed with a curative intent for this patient. The number of mets is important.
You can always divide them based upon the location of the metastasis, whether the metastases are involving axillary skeleton or appendicular skeleton. If the appendicular skeleton is involved and there is only a single metastasis or oligometastasis as you have described, then you can always go for a curative excision. While doing the chemotherapy, you can go for a curative excision and then you can do a reconstruction with graft or you can do a stabilization. Whereas in case of axillary skeleton which is involved, and again you can depend upon whether if it is a multiple or single metastasis. If the multiple metastases are involved, and again you have to classify whether they're causing any extradural component causing neural compartment compression and all. And based upon all these structures, your management completely differs. So you can't say if it is an oligometastasis or multiple metastasis. You have to describe based upon the typical location and all. So you have given the chemo, you have completed your surgery for your patient. So what is the adjuvant therapy that you're going to prescribe?
Depending upon the
You have 2 minutes more. You have 2 minutes more.
depending on the immunohistochemistry finding, we will proceed with the adjuvant therapy that we are going to give, and also the results of the histopathology.
What are the types of adjuvant therapy that you're going to give?
There can be hormonal therapy based upon the receptor status, ERPR positivity. HER2 positivity can be managed with trastuzumab and pertuzumab. Then we have radiotherapy as adjuvant therapy as well as the immunotherapy.
Don't you want to give adjuvant chemotherapy for this patient?
Yeah. Yes. Based upon the
adjuvant chemotherapy,
we'll find the need for adjuvant chemotherapy. Tumors which is more than 1 centimeter, or high-risk tumors which are more than 0.5 centimeter. That is with lymphovascular invasion, with triple negative disease, or with axillary nodes. I'll go for adjuvant chemotherapy.
can both chemotherapy and hormonal therapy be combined?
No.
First
chemotherapy.
What is the reason?
Then hormone.
What is the reason?
Hormone therapy acts on the receptor status. So chemotherapy inhibits the production of protein synthesis, and there are no receptors for the hormone adjuvant drugs. Hormone therapy drugs to
You
act.
can also term it like chemotherapy agents act on the actively dividing cells.
Yes.
And hormonal.
Once the hormonal therapy is given upfront, then there won't be any actively dividing cells for chemotherapy agents to act upon. So you can't give chemotherapy both combined. So what is the hormonal therapy that you want to give in this patient if the patient is having ERPR positivity?
Tamoxifen can be given in case of premenopausal women, where we are giving 30
In your
milligrams.
patient.
In your
My
patient,
patient
this
is
is postmenopausal.
I will give her aromatase inhibitors. Letrozole or anastrozole is given. Anastrozole 1 milligram or letrozole 2.5 milligram can be given.
Your last question.
If the patient is a premenopausal woman, what do you want to give?
Tamoxifen.
Can be given.
Why can't you give aromatase inhibitors in case of a premenopausal woman?
That will cause ovarian suppression.
Ovaries.
Tamoxifen is a selective estrogen receptor modulator. So we want only anti-estrogenic effect at the breast level.
And also, ovary is the source of hormone in premenopausal women. So if you do not, if you just give aromatase inhibitors that do not, it is the non-gonadal suppression that aromatase are offering. That is the peripheral conversion of DHA into
aromatase inhibitors inhibit the enzyme aromatase, which helps in conversion of testosterone to estrogen. So there won't be any estrogenic effect which will cause atrophy.
Thank you very much. Dr. Luth's team can make the presentation now.
Thank you, sir.
Thank you.
Good evening. Team Looks presenting the case of 55-year-old lady. Is a homemaker coming from Ernakulam, belongs to a lower middle class family. Presenting with cheek complaints of complaint of swelling in front of neck since 5 years, complaint of loss of weight since 5 months, and complaint of trembling of fingers since 1 month. History of presenting illness. Patient was apparently normal 5 years back when she noticed the swelling in front of her neck. It was insidious in onset, gradually increased to attain present size. The patient gives history of loss of weight in spite of increased appetite over the past 5 months. She was unable to mention exact weight loss, but reported her clothes getting loose. Since past 1 month, patient has been complaining of trembling of fingers. She also gives history of inability to withstand high temperatures with excessive sweating. No history of fever, pain, or the swelling. No history of compressive symptoms. No history of sudden increase in size. No history of chest pain, exertional dyspnea. No history suggestive of metastasis. No history of any disturbance in bowel and bladder habits. No history of any other swelling on the neck. No history of any eye symptoms. Past history, no relevant past history, no history of irradiation to neck in childhood. Personal history, takes mixed diet, appetite normal, increased sleep disturbed, appetite increased, sleep disturbed, normal bowel and bladder habits, no addiction. Menstrual history, attained menarche at 13 years of age, 28 days, regular with normal flow, attained menopause at 50 years of age. Family history, married, having 2 children, no history of any thyroid-related disease in the family. Summary is a 55-year-old lady presented with complaints of swelling in front of neck since 5 years, associated with the loss of weight despite of increased appetite and trembling of fingers. She also gives history of heat intolerance with excessive sweating, disturbed sleep, no compressive features.
General physical examination. Patient was examined in a well-lit room with adequate exposure after obtaining consent. She looks nervous and anxious. No pallor, icterus cyanosis, clubbing, edema, and generalized lymphadenopathy. Carnosity 90. Palms are warm, moist, and sweaty. Fine tremors noted on outstretching of hands. No toxic eye signs or muscle wasting. Examination of oral cavity, skull, and spine is normal. Average built-in nutrition. BMI 19.2 kg per meter square. Vitals, pulse rate is 102 per minute, regular rate, normal rhythm and volume. Other vitals are within normal limits. Local examination, inspection, a swelling of size 6 cross 5 cm noted in the anterior part of neck, extend between the anterior borders of both sternocleidomastoids horizontally, superiorly up to the level of the thyroid cartilage and inferiorly up to 1 cm above the sternal notch. Surface appears smooth. Skin over the swelling is normal. Swelling moves upward with the deglutition. Lower border of the swelling can be seen. On extending the neck, swellings become less prominent. Component sign negative. No visible pulsations, scars and sinuses. No dilated veins over neck and chest. Palpation. Inspiratory findings were confirmed. No local rise of temperature, tenderness. A bilobe swelling of variable consistency with multiple nodules, irregular surface and well-defined margins was noted over the anterior aspect of the neck. The largest nodule in the right lobe measured approximately 4 cross 3 cm, while the largest node in the left lobe measured approximately 2 cross 1 cm. Circumference of the neck at the most prominent part of the swelling is 30 cm. Not fixed to overlying skin. Swelling is mobile horizontally and vertically. Lower border of the swelling is palpable. No thrill or pulsations palpable over swelling. Carotid pulsations are palpable on both sides with equal intensity. Trachea is central. No cervical lymphadenopathy. Examination. No. Percussion resonant over upper part of sternum. Auscultation, no bruit heard over swelling, superior. Systemic examination. Serious respiratory per abdomen within normal limits. CNS, patient look anxious, fine tremors present, deep tendon reflexes exaggerated, power, upper limb and lower limb 5/5. Summary. 55-year-old female presented with the complaints of swelling in front of the neck since 5 years, associated with loss of weight despite increased appetite, trembling of fingers. She also gives history of heat intolerance with excessive sweating, disturbed sleep, no compressive features. On examination, patient is anxious, shows fine tremors and tachycardia, a bilobe nodular swelling of variable consistency, noted over the anterior aspect of the neck, which moves with deglutition and lies deep to the deep fissure. Trachea is central and component sign is negative. Diagnosis multinodular goiter with toxicity.
Good presentation. Sir, shall we start questions?
Please, 10 minutes, 20 minutes, yes.
So your diagnosis is multinodular goiter with the toxicity. So from history, can you mention what are the points that suggested this patient has developed thyrotoxicosis?
It is a female patient with complaints of swelling over the anterior aspect of the neck with signs of toxicosis like sweating, tremors, disturbed sleep, and loss of weight in spite of increased appetite.
You didn't heat intolerance, you had said.
Heat intolerance.
You didn't.
Sweat.
Okay, fine. How will you differentiate primary and secondary thyrotoxicosis from your history?
Usually, primary thyrotoxicosis will be having CNS symptoms more, and ophthalmopathy, eye symptoms will also be more. Whereas in secondary thyrotoxicosis, cardiac symptoms will be more. So from that, we can differentiate from the history.
Patient will complain of chest pain and exertional dyspnea in case of secondary thyrotoxicosis. Whereas in primary thyrotoxicosis,
yeah. Continue. Continue. Can you hear us?
Next question.
Yeah, we can hear you.
Okay, can you hear us, sir? Are we audible?
Yeah, please.
Yeah. And in primary thyrotoxicosis, the swelling comes along with the features of thyrotoxicosis, or the thyrotoxicosis might come first and then the swelling. In secondary thyrotoxicosis, there will be a long standing
swelling will be there, long standing swelling will be there, and the thyrotoxicosis features will become.
Okay.
What is the difference between hyperthyroidism and thyrotoxicosis? What is the difference between hyperthyroidism and thyrotoxicosis?
Thyrotoxicosis means that it is a manifestation of the increased thyroid hormone. Whereas hyperthyroidism means it is the gland is producing more thyroid hormones. So thyrotoxicosis can be due to other reasons also, like factitious stroma ovary.
Can you say some causes where thyrotoxicosis is present but the gland is normal?
Yeah, like stroma ovary, where it is produced by the ovary. Then factitious, where the patient is taking more thyroid hormones. Then choriocarcinoma, it can be there.
Hydatidiform mold.
Choriocarcinoma.
What are your differentials for a toxicity with thyroid swelling?
It can be a diffuse, it can be Graves' disease, a toxic nodule, autonomous nodule, toxic multinodular goiter.
It can also be thyroiditis, right? In case of
Hashimoto's thyroiditis also, first hyperthyroidism will be there,
So when there is thyrotoxicosis, what is the most common symptoms that patients present with usually?
Most common CNS symptom.
CNS symptoms, neurological symptom.
Irritability, agitation, nervousness.
Most common.
There will be physiological fine tremors. Your patient has.
Like in our patient, we had fine tremors for our patient.
So your patient, if your patient was normal yesterday and today she is complaining of sudden increase in size of the swelling with pain and breathing difficulty, what will you suspect?
It is most probably because of any bleed inside the thyroid gland because of increased vascularity, which is compressing the trachea, that can cause breathing difficulty.
Okay. So moving on to examination, you have a toxic patient. Is there any importance of commenting on if edema is present in this patient or not?
Yeah, there is definitely. In case of secondary thyrotoxicosis, usually pre-tibial mixed edema is seen in. It is because of glycosaminoglycan deposition.
And also congestive cardiac failure, pedal edema can be there for the patient.
In secondary thyrotoxicosis, pedal edema, and in primary thyrotoxicosis, pre-tibial mixed edema.
Yeah.
What is the role of importance of examining a pulse in a toxic patient?
The pulse rate will be mostly higher tachycardic. It is graded according to the trials grading, where you can grade it according to whether it is less than 90, 90 to 100 or greater than 100.
Most common cardiac manifestation is atrial fibrillation. So you should be looking for the pulse, whether it is regular or irregularly irregular. Also, patients with the secondary thyrotoxic will have high output cardiac failure, in which while checking the pulse volume, which will be collapsing, get a diagnosis.
Which is the eye sign that you are expecting to be positive in your case, that is secondary multinodular toxic goiter, multinodular toxic goiter, which is the eye sign that can be positive.
Lid lag.
Yes. Lid retraction. Why does lid retraction occur?
It can be due to overactivity of involuntary smooth muscles of
What is the muscle called?
Levator palpebris
superiors.
What is the
Muller's muscle.
Muller's muscle.
Okay. How do you examine elicit the Mobius sign?
How do you?
Mobius sign.
Mobius sign. Mobius eye
You
sign.
ask the patient to converge the eyes to a point. You ask the patient, you fix a point and ask the patient to look at that point in the midline. So the convergence will be
lost.
No, first you have to ask the patient to look at a distant side. Then you have to suddenly bring an object in front of the patient, and you should look for whether there is convergence of eyeball, constriction of pupil,
and curvature of the anterior lens that will help the patient to accommodate.
That is what you're looking in the Mobius sign.
So you have mentioned lid retraction. What is the normal position of upper eyelid and lower eyelid with respect to cornea?
Usually, upper eyelid covers almost 1/3 of the cornea, whereas lower eyelid just lies below the pupillary surface.
Yeah,
At
upper
the
eyelid
level of
around
the limbus.
1/6 of the cornea. That will come around 1 to 2 millimeter. And the
What is the difference between exophthalmos and proptosis?
Proptosis is protrusion of eyeball because of deposition of periocular tissue. In case of exophthalmos, it is just simple protrusion of eyeball.
When it is due to a thyroid condition, it is called exophthalmos. When it is due to secondary conditions such as soft tissue swelling or orbital pathology, then it is called proptosis. How will you do a classical Coker's examination in a thyroid palpation?
classical.
Coker's method.
Coker's
So
test
it's not usually done now. It is
Not
to
Coker's-
you
Not
are
Coker's test,
method of
Coker's
examination.
classical Coker's method of thyroid gland palpation, not Coker's test.
you stand in the behind.
Behind.
You stand behind the patient and the thumbs are kept in the occiput and with your fingers you palpate the thyroid gland.
so you have mentioned the trachea central in your examination. How did you check for that?
Use a 3-finger test to check the tracheal.
We keep the the index finger and the ring finger over the what?
No, please explain, please explain.
Yeah, we use the 3-finger test in this case. You keep the ring finger and the index finger on the sternal in the clavicular where the clavicular head of SCM, and then using your middle finger you palpate for the trachea. It is central in our case, or else you can also auscultate and find out, or you can also use the radiology to find out the position.
You said that you didn't get any bruit in your case. Where do you look for bruit?
We usually look for the bruit in the superior pole. That is where the superior thyroid artery is joining. That is the usual position of it.
Why are we looking for superior thyroid artery in bruit, not other vascular supply?
That is the most easily approachable by us. We can only keep it there. Inferior thyroid artery we cannot usually auscultate for.
Also, the superior thyroid artery supplies the surface of the thyroid gland, so it is easier to get there. Also, do you look for venous hump?
Do you look for
venous hump?
We can also look for venous hump, but in our patient it was not there.
Where
due to hypervascularity, you can also get
in thyroid.
In the superior.
In primary or Graves' disease, there can be bruit as well as venous hump.
So you mentioned carotid pulsation also. What is the normal position of carotid pulse? You palpate.
It is palpated against the C6 vertebrae. That is a chesagnes tubercle.
How can you identify the C6 vertebrae? How did you identify the C6 vertebra for carotid pulse palpation?
The level of thyroid cartilage. The level of thyroid cartilage.
An imaginary line drawn at the level of the upper border of thyroid cartilage, which joins with the anterior border of the sternocleidomastoid. That is where you should be palpating for carotid pulsation.
If you do not get a pulsation at this level, what do you do next?
You can look for the carotid pulsations posteriorly, because the large goiter can displace the carotid arteries, or else we can.
So after clinical examination, how will you further proceed in this patient? What next steps we will be doing?
We do quadruple assessment in this patient. As we have already completed the clinical examination and history, we proceed with thyroid profile, T3, T4, TSH, and then we can do ultrasonological assessment of the neck. Then we can proceed with FNAC of the thyroid.
What is the normal range of TSH and FT4?
TSH is usually between 0.5 to 10.
Sorry, 0.5
milli
to
international
5.
units per liter.
TSH is usually 0.5 to 5 milli international units per liter. FT4 is 10 to 30 nanomole per liter.
So we test for free T3 and free T4. Why not total T4 and T3? Why are we not
Total
putting?
Total T3 and total T4 are protein bound.
Thyroid binding globulin is it will be bound, so the values will be wrong. So free T3 and free T4 is mostly checked, but it is costly and it is not usually checked.
Protein in our body.
Okay. So why did you look for free T3 specifically in your case?
In thyrotoxicosis, sometimes free T3 alone can be raised without any raise in free T4.
What is it called? It is called T3 toxicity, which is usually more commonly seen in multinodular toxicoitis, not the other kinds.
Okay. So what do you want to do next? You have done a thyroid function test. Now next.
We'll go with the ultrasound of neck. Then we'll go, in our case, we haven't actually done
high resolution ultrasound, right? High resolution ultrasound. So what?
high resolution ultrasound with doc.
By doing an ultrasound in this patient? Why do you want to do an ultrasound in this patient?
In this patient, actually, in a long-standing multinodular goiter, there is a chance of papillary carcinoma, which can be seen. Follicular carcinoma, which can be seen. To look for the characterization of the gland, and then we can also look for the nodal status in case of if there is any papillary follicular carcinoma.
Also in toxicity, there can be increased vascularity in the gland. You can also look for
so
a direct.
using a Doppler. Using a Doppler, we can.
Right. Yes. You said that some of the nodules were irregular. So irregularity is also something that you have to be scared of. So you have to take ultrasound and also probably if it is high, FNA from the corresponding irregular suspicious nodule.
So after doing FNAC, you are getting a Bethesda report. Whether Bethesda 1 or 2, which is more malignant?
Sorry?
Bethesda 1 or Bethesda 2? Which one is more,
Bethesda 1 is more
more malignancy?
Right.
Bethesda 1 can be more malignant.
Why?
Bethesda 2 is
Bethesda 2 is confirmatory of benign, whereas Bethesda 1 is
non-diagnostic.
So it is obvious.
Do you want to do any radionuclide scanning in this patient?
Pardon?
Any radioiodine scan, radionuclide scanning?
We actually did not do radio scanning in our patient because our plan for this toxic multinodular goiter in our patient was total thyroidectomy. Doing a radioisotope scan was not going to change our management. So we did not do actually.
Name some indications for radionuclide scan in a preoperative patient toxicity.
We can do in autonomous toxic nodules. We can find the difference between primary, secondary, and toxic nodules. We can also look for ectopic thyroid if it is there. We can also look use it for looking recurrence, metastasis, etc.
Okay.
Preoperative.
So also to differentiate first episode of Graves' disease from thyroiditis.
You have 8 minutes more. 8 minutes more.
Suppose you are doing a scan in this patient. What will happen? What will be the finding?
In this case, in this patient, there will be patchy nodular uptake. In this patient, there will be patchy nodular uptake rather than a diffuse uptake.
Where will the uptake be?
Sorry?
Where will the uptake be? It will be more in the internodular tissue.
Internodular tissue.
Okay. How do you plan to proceed? What is the surgical option you will give this patient?
As our patient is having a large nodule and involving both the lobes of the thyroid, we will advise the patient to proceed with total thyroidectomy.
Anything else you want to do prior?
Prior to surgery?
Sorry?
Prior to surgery, do you want to do anything?
Yes. Patient should be brought down to the euthyroid state. Patient will be given antithyroid drugs along with to control the tachycardia and the sympathetic drugs. We will also add propranolol at the end of the antithyroid treatment.
Other antithyroid drugs you know about? Other antithyroid drugs you will be using?
Thimerosal, iobricosol, propyl thyroid acid. Then you glucoside or old.
Carbimazole and neomercazole both are same.
Methymus.
You mentioned propranolol in your case. Suppose this patient has asthma. What will you give?
Patient can be given nadolol in case of bronchial asthma.
Calcium channel blockers instead of propranolol. Usually verapamil and diltiazem are given.
So you have brought the patient to a euthyroid status. So what is he going to do next? A surgery?
Yeah, next we are planning for total thyroidectomy for this patient.
So what
after bringing the patient to euthyroid state, total thyroidectomy is planned for our patient.
Okay. Do you know about Hartley-Dunhill procedure?
Hartley-Dunhill procedure can be done, but we have advised
No, what is Hartley-Dunhill procedure? What is Hartley-Dunhill procedure?
What is Hartley-Dunhill procedure?
It is one side lobectomy, isthemectomy, and the other side near total lobectomy.
Subtotal.
With the remaining of 4 milligrams of tissue.
Suppose you are proceeding with total thyroidectomy. What is the most common nerve to be injured?
Recurrent laryngeal nerve.
ESP.
Sorry, it's external branch of superior.
Most common is external branch of superior laryngeal nerve. We have to most careful to be.
Yeah, sure. According which Serenese classification is more likely to get injured?
2B.
Why?
According to Sernia classification, 2B is most likely to get injured because it is most closely to the superior thyroid artery. And so when you are ligating it,
laryngeal nerve.
Pardon?
Branches of recurrent laryngeal nerve.
Before getting into the laryngeal inlet, you will be giving branches to the larynx. And
there's a motor branch and sensory branch, that is abductors and adductors.
The two adductor motor has two branches, abductor branch and adductor branch.
And the sensory part is called nerve of Gallen.
Sensory below the sensory
Name
below the
some
vocal
novel
cord is also
techniques
separated.
to identify parathyroid in the intraoperative period.
Pardon? You didn't get you.
Novel techniques to identify parathyroid gland in the intraoperatively.
You can use methods are when you press it, it's the dictum that it is angry when touching. That can be looked. Then
okay. You can use either indocyanine green or
ICG you
near
can be
infrared
using.
immunofluorescence technique to identify NIRAF, near immunofluorescence. Sorry, near infrared autoimmunofluorescence.
Okay, let's say you've done a total thyroidectomy. In the immediate post-op period, you see the patient is having stridor and breathlessness. What do you do immediately?
Sir, are we audible, sir?
You are audible, but they seem to have been frozen.
Okay. Are we audible?
Yeah.
Yeah.
Can we repeat the question?
Yeah, repeat the question.
Okay, so you've done a total thyroidectomy in this patient, and in the immediate post-operative period, the patient is complaining of sudden onset breathlessness and dyspnea and stridor. What do you do?
Again, they seem to have lost their activity.
Shall we answer?
No.
Let them come in.
Yes, sir.
Will compensate for the time loss for yours. Because
yes, sir.
It's about a 1 minute more.
Okay, sir.
You can mute, unmute. Yeah, go ahead.
Sorry.
Yeah. So in the immediate post-operative period, if the patient is presenting with stridor and distress, we should always suspect hematoma formation. If there is any hematoma formation, we should take the patient for immediate exploration.
We remove the suture and explore. If there is any active bleeding, we remove.
Where will you remove the sutures?
Which part of sutures will you be removing?
The deep fascia has to be opened, right? Just not the skin sutures. The deep fascia has to be opened.
And also it can be bilateral recurrent laryngeal injury or laryngeal edema, which also has to be kept in mind.
So in the immediate post-operative period, if a patient develops a high temperature, stupor, and with the agitation, what will you think in such situation? Tachycardia, fever?
Thyroid storm in this patient.
Pre-thyroid storm.
Thyroid storm, the first treatment we are giving steroids for this patient. Then, according to symptoms, if the patient will be having hyperpyrexia, so cold fluids, tepid sponging, everything is given. Then, to decrease the thyroid hormone load, we are giving anti-thyroid drugs also.
We have to give beta blockers to compensate for the sympathetic effects.
Can you name some beta blockers which are given orally or IV? Which one will you give?
IV beta.
Can you suggest some options for it? IV propranolol and IV esmolol is given. And also dehydration, it is better, safer to ship the patient to ICU just to give some more. And steroids, what are you giving? Which kind of steroids?
Dexamethasone IV.
Okay.
So you are suspecting hypocalcemia in your patient while you take post-op rounds. Which are the clinical examination signs you want to elicit?
The clinical signs are Chostek sign and Trocher sign. Chostek sign, when you tap on the preauricular area, there will be twitching of the muscles to the same side. And Trocher sign.
That is Chostek sign.
Yeah,
Chostek. Chostek is this, and Trocher sign is when you keep a sphygmomanometric cuff, you increase it to 200 millimeter, there will be carpopedal spasm will be seen.
Which is more sensitive?
Trocher or Chostek?
Trocher is more sensitive.
Suppose this patient, not this case, a 70-year-old patient comes to you. Okay, he is not fit for surgery, multiple comorbidity. Is there any other option that is not actually used nowadays and like not used in our setting? Option that you can offer?
Yeah, you can offer radioiodine ablation. You can give. Then alcohol injection. There are other methods that we don't use usually, like alcohol injection, etc.
Radio frequency ablation can also be tried.
What do you have to look for radioiodine before giving? Like, what is the absolute contraindication or what you should watch for?
Pregnancy and lactation are the absolute contraindications.
In this case, a 70-year-old male, you have to look for imminent tracheal compression retrosternal extension. Because if you give radioiodine, if the patient
the size will be increased,
then that is counterproductive.
You have 2 minutes more.
Why are we not doing surgery in case of recurrence?
Why are we?
Why are we not doing a completion thyroidectomy in case of a recurrent thyroid swelling after total thyroidectomy?
So you have done a total thyroidectomy for a MNG. Now the patient has came you with a small recurrent swelling, which you have confirmed it is a thyroid tissue. Will you go with a second surgery or you will give any other option?
We can go with iodine ablation in this patient.
What is the percentage of malignancy occurrence in your case?
In our case, the hypertoxic MNC, so 8 to 10% malignancy can also occur.
Fine.
What will be the clinical features in case of Graves' disease? Graves' disease, what will be the clinical and examination features?
There will be signs of Graves' disease. The most it's a primary thyrotoxicosis where eye signs and neurological symptoms are more common. Patient will complain of tremors and there will be ophthalmoplegia.
Can you discuss about the thyroid gland in Graves' disease?
Thyroid gland?
In Graves'
disease. Clinically, on examination, how will be the thyroid gland?
It will be a diffuse swelling. It will be firm.
Nodularity. Is nodularity possible in Graves' disease?
Yeah, nodularity is possible in Graves' disease.
What is that syndrome called?
A long-standing Graves' disease, which develops a nodule. What is that syndrome called as? Marine-Langhart syndrome. Marine-Langhart syndrome. So,
last question.
How will you name one novel technique for assessing the vocal cord status in your patient?
We can do a video laryngoscopy preoperatively.
Any novel technique?
Newer technique that we have.
Novel, non-invasive technique for vocal cord assessment.
Preoperative video laryngoscopy.
No, that's commonly used.
You can use transcutaneous laryngeal ultrasound. Transcutaneous laryngeal ultrasound, where you can see the direct mobility of the vocal cord status. The only disadvantage is in some patients where the thyroid cartilage is more prominent, it won't allow the ultrasound waves to pass through.
Thank you very much. We'd like to close.
Thank you, sir.
I'll just request our esteemed panel of judges to make comment this time. Can I have Dr. Vikram Karte as the first person?
Okay, thank you very much, Professor Santosh, first of all, for this opportunity. It was wonderful, something very unique. I have seen it for the first time. And many congratulations to all the 16 people. I did not mention any critical comments earlier because I thought another set of teams is going to present. But little bit, I will first, as I said, these group of 8 students also have done it very wonderfully. A few suggestions I would like to give them. They are students. Of course, it will take many more years to become seasoned examiners. But I feel that overall, all the 16 people, it is better to have a conical or a funnel approach. So that means what I mean is anti-grade approach. Most of the 4 teams, they use the retrograde approach. That means they started the questions based on the diagnosis rather than following up. How do you come from the patient to the diagnosis? So many of the questions were targeted at that. Then many of the questions I felt were leading questions. And instead of that, it is always better to have open-ended questions. So when you have an algorithmic approach, you just go step by step in a open-ended question. Then some of the questions, I'm not saying many, but they were not linked directly to the present case. So when we have a case presentation, it's better to have that rather than bringing more of theoretical questions. And lastly, as I said, again linked to that, that some of the questions were standalone questions, which might be more of theoretical knowledge questions. So a lot of theory was discussed in all the 4 sets and a lot of knowledge. So it will be a very good resource for the students to learn, definitely. But that can be little limited because we always have a theory exam before the practicals. So in the practical, we directly have a clinical approach. So those are the things. But once again, I'd like to say that all 16 of them, they are students, and at the students level to perform as examiners is extraordinary. Many congratulations. Thank you very much.
Thank you, Professor Tulkate. Professor Abhay.
Yeah, I'll come in here for the students who are listening. When you appear for an examination, there are 4 types of examiners you'll get. First one is the convener. He is all with you. He wants to pass you under any circumstances. The second one is a specialist in his or her own field who has more knowledge, as was discussed in the presentations, which I have made it clear that at MS level, I do not want these discussions to go on. The third type of examiner is I know more than others. They are fighting among themselves. And this is what I saw in the second presentation right now, when one of the teams, I'm not going to name, was trying to kill the other, not the team. They were trying to kill others through mere clinical examination, and it was a very well thought of strategy. The fourth thing with the examiner that you should know is to divert questions. When history examination tells you that this is malignancy, it's very nice for an examiner to divert you into benign conditions and try and get you not into trouble, but how much you have read. Because everybody knows, you all know your diagnosis beforehand, and the questions go on. So these are some things which I personally feel for all the people who are listening, and I'm surprised that the previous 2 people have left. I thought initially that I was supposed to take only for 2 people, and 2 other people had joined, which I was questioning Santosh all the time. Who are these other people? But you all had come in very early and listening to what was going on the other side. And that's why if your surname is good, you'll be on the day 2, because you will know what is going on the examiner's side on day 1. And once you know that, you can be well prepared for presenting your cases for MS examination. For me, Kottayam, don't be very harsh on the other people who are this. You knew what to do. And that is one of the types of examiners that you are, especially the one in black. I can see her face. Yes. I would like to meet you. I'm coming to Kochi sometime in June. And if I have time, I would like to. No, you are good. and you will do well in life. I'm telling you for sure. Lauders has tried to defend very well, both the girls as well as the boy. So it's a tough competition. I'm not going to take any decision about it. I'm leaving it to Santosh and Prabol.
No,
What?
not my decision.
Don't
No
put.
decision at
See,
all.
for me,
I will
all
not.
four are passed. Anyway,
No.
I'll give you a personal choice.
No.
I will give you my personal choice,
I'm
Santosh.
sorry. I'm just a platform provider.
I know.
And you need to select between three of you. You just decide what.
Yes. We will consult.
Incidentally,
I will form a
let
separate
me.
WhatsApp group and come to a conclusion.
Yes,
But
yes.
this is as a retired person, I'm just telling you that as an examiner and as a
we had,
presenter, there are two different things. Thank you so much, sir.
Dr. B, before I call on Dr. Niyogi for his comments, we had actually two people in this panel. In Calicut, we had Ilsana. She stood first in the RRC last year, and she is heading to America. And Kirtana, she stood fourth in the national level, and we actually asked her for a debate at national at RRC. So, they are good people. And just for your information, and Prabodh must be doing about that. And for
Santosh,
Prabodh,
then I'm sorry for pointing out finger at her.
No. I'm just getting
She's good, but she knows to be an examiner, and she's a future teacher. That much I can tell you.
Prabodh, please.
Yeah. Thank you for a very unique opportunity to judge a contest which I have never examined or been a judge to. And I feel it is an excellent pattern. I think Kerala has always been leading from the front, and we can implement this in other states as well. Students examining other students, I think because they know what you are, what you feel, I think that is an excellent concept. Regarding the questions, I, as an examiner, often what we do is, see, when you are given a topic, you usually the examinees know what cases they are going to get, and they know, they study about it much in detail, that as you have all done when you knew the case. Whereas in an exam, probably the level will not be as high as what you are talking right now, because you have a multiple number of cases, and so the discussion might not go to that level. I agree with that. So what we do often to judge a candidate, suppose somebody does not know about retroperitoneal sarcoma, we ask questions which are off the topic also. So that is also a way to judge how much this person knows, because he may not know about this particular thing, but he should have this is a general exam for postgraduates, in which you are supposed to know everything from top to bottom. So we often do that. We give questions which are away from the topic to judge the other team. But you did a great job, all of you, I must say, and the standards were amazing. And I know a couple of you. I've seen you in RRCs, and we know that Ilsana is going out as well for she's won a prize in the TISA, and absolutely, it will be very difficult to judge because all of you are winners. So it will be very difficult for us to judge. But of course, there has to be number one and number two. We will let you know. We'll talk amongst all the three of us, Dr. Vikram Kate, Abhay Dalvi sir, and myself, and then we'll come to a decision and let you all know. But congratulations to each one of you. There's no winners and no losers in this round. Thank you.
Thank you.
Just 30 seconds I'll take. For all the residents who are listening to me, in my whatever 40 years of career as a medical teacher, there are 4 types of residents that I have always seen. Number one, who doesn't require your help. He or she just goes ahead. The second one are the people who know their limitations and continue to practice what they are good at. Is the third and the fourth one who are challenging for a teacher. The third one is the one who is doing well and somewhere down the line goes down. I do not know. It could be any reason. And that has to be picked up. And the fourth one are the people who don't improve at all. If a good teacher, and you all are future teachers, are going to become one of them, keep an eye on level 3, level 4, and believe me, at end of your career, you will bless yourself. And that is what I wanted to get. That's why the single reason why I said yes to Santosh. And this is my experience. All of y'all, wish you all the best as future teachers. And I hope I'm with you for some other years to come. And I'm ready to help you all the time. Thank you so much. God bless you all.
Thank you,
Thank you, sir.
I think Santosh is offline.
Okay.
Ranjan, you need to
Okay.
thank.
Santosh sir might have gone offline. So it was a very well fought match. All the team had done extremely well. Their preparations were extremely good. And also we had a big panel of judges, Dr. Abhay Dalvi, Dr. Prabol Niyogi, and Dr. Vikram Kate. Thank you, sir, for coming to our platform. And actually, with your presence, we are blessed, and your comments were all very valuable and very good. You can put the marks and the results you can hand over to Santosh sir and invite Madhu to if you say a few comments.
Nothing. Hi, Kati sir. Hi, Prabhu sir. So before this, we had, just for information, sir, we had 4 quarterfinal matches, and before that, first round matches were there. The competition among the students is very tough. And more importantly, all these students have a mentor. The competition among the mentors is also very tough. That's why we thought for the semi-finals, we want to have neutral judges from outside the state. That's how Santosh sir picked you, 3 of you. So nice of you that you joined and judged the students.
Yeah, definitely.
And the finals will be coming live on the stage during the state conference, sir.
Unfortunately, you won't be there for catch-up. If you are there for the catch-up, we would like to have you all judges for the finals as well. So, Santosh sir, can I make one point?
Santosh sir came in.
Yeah, next week and Saturday and Sunday, we do have our state level conference. Whoever 2 teams you select, they will be fighting on site at Kannur. Live. We'll see whether we can have a connectivity. Let's see. Madhu, we'll try to see whether we can have a connectivity there.
No, sir, just to be neutral. Sir, can I make one point, sir? Santosh sir,
but Dr. Marthapandian will be there as our chief guest. So he can actually be one of the examiners. Let's see, let's finalize based on this.
Just one last point, sir.
I think yeah.
Sir, just one word to judge, just to be very absolutely neutral. I would suggest, sir, please put your marks. And with permission of Santosh sir, I would suggest that please don't send it to Santosh sir. Send it to Ranjan.
Please
because,
yeah, I will share. I'll share the number.
Yes, please.
I'll share the number of Ranjan because there could be some objection for me being there. In where my postgraduates are actually contesting. Though I have not prepared anything for them, and it's Vimal who is taking care of it, but then there could be some objection. So I'll share the number with Dr. Ranjan, our State Chapter Secretary, or even Mathu is fine. And we can decide whichever team it is.
So what we'll do, we'll mark out of whatever, and
you decide whatever it is, sir.
Yeah.
You just decide. You just decide whatever it is between 3 of you.
Prabol and Dr. Kate, I'll form a common WhatsApp group between 3 of us.
Yeah.
We'll decide and send the results by tomorrow.
Yes.
Let's not delay.
Yes, sir.
Because we need to allot the cases for the finalists.
Yeah.
Which will happen next round.
And my suggestion to you is today's discussion was on similar cases. So if you have little different cases in the final round. It will be
Yes,
much
sir,
better.
we had
No,
different
it is
cases.
completely different because
I
it's
know you will
completely
do
different.
it. I know, I believe in you. So that's not an issue at all. But today, both the teams, I personally felt that the second teams had a little more advantage because questions were asked initially on CA breast as well as thyroid, and everything was, and that's why I personally felt that they came in with an opposition as examiners, which was really ready. And that is where my dilemma is right now, to whom to select from the second one. But that's
Sir,
okay.
actually, we are not selecting on knowledge. We are selecting how they conducted themselves
Correct.
as
Future
examiners,
teachers. Future
as
teachers
teachers.
is our
What was their
goal.
behavior,
Correct.
their way of asking? What was the? It was
Total,
all
I
about
have
their knowledge.
jotted down everything in my legible handwriting. So we will discuss. Kate sir, thank you for joining us, because
Thank you
you
very
are
much.
one of the
Pleasure.
respected persons in Association of Surgeons of India. आणि तुम्ही, I know you know Marathi, so little bit in Marathi. Thank you for coming. म्हणजे धन्यवाद.
So, on behalf of the Kerala chapter, let me profusely thank all the three examiners. You found time, that too at the very probably an untimely hour, I would say, 8 o'clock
No,
to almost.
Santosh, I will introduce this in Mumbai at least, and also try and
Call
put it in
me as
Maharashtra.
an examiner.
Yes.
And you will be examiner for 2 hours.
Judge, sir.
Yeah.
No. I'm just
Okay.
joking. But this is something which we thought that we will have a different
It's a
kind
very
of
good idea. It's an excellent idea.
different kind of, and involve more number of people.
Correct.
Because all these students will have to prepare for, and that will be actually a preparation for their MS DNB exit examination.
Absolutely.
So they actually get prepared for two cases, one for their own case and one for the other team. And as Abhay has rightly put, or Prabhu has rightly put, the person who prepares for a toxicity naturally will prepare for a malignancy and early breast cancer, late, LABC like
This is
that.
the third year, sir. Santosh sir, this is the third year. This is the third year we are running the show.
Fourth year, 23 we
Fourth
started.
year, fourth year.
This is the fourth year.
This is the fourth year. Fourth year. As we grow, as we move further, the emotional attachment for the mentors actually is climbing up.
Very tough to deal with the mentors. When one team loses, it's absolutely shattered.
And that's why, and probably we'll have all external examiners next year to avoid all kinds of criticisms. First year we tried with the same group of examiners from within Kerala, then moved to another pattern. Like that, we also are improvising. And this year again we had a small problem. We initially started with 20 teams. And we insisted that all should be ASI members. We ended up in 18 teams, which meant that 18 into 4, we have already become ASI members.
Wow.
18 teams into 4 students, they became ASI members.
Very good.
So like that, there are incentives. We'll give some incentives. These people will get a good prize money. We'll try to give something. Okay, then. Thank you very much.
Good night. Good night. Bye-bye.
You.
Bye-bye. Thank you.
Good night.
Thank you.